लॉबी में है ना तुम? Hello, Sampada. Hello, Sampada. Hello, Sampada Kulkarni, ma'am.
Hello.
Madam,
Hello.
you are the co-host now, and
Oh, okay, sir.
you can take ahead on this now. Hello, Dr. Ajit. How are you, sir?
Good, good. How are you, Rahul?
Very fine, sir. Thank you very much.
सर क्वालिटी का होस्ट कौन है वो स्क्रीन शेयर नहीं करता
Hello, check. Hello. Hello, check. Check. Hello. तिकडचं पण घेऊ. आपण तिथे जाऊन चेक करतो ना येतोय. Hello, check. Check this. Hello, check. Check this. Hello, check. मला नाही येते सर.
हा करण हॅलो
आला आला. येस येस आला सर. आला.
हॅलो. ते व्हर्च्युअल हे करायचंय ना, ते कसं करायचं?
श्वेता मॅडम आपला आवाज येतोय.
Hello. 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 Good afternoon, everybody. I'm Dr. Santosh Bhide here. Can you hear me? Hello, Rahul.
Yes, sir. We can hear you.
Dr. Medha is also
Your
there.
voice is audible.
Achha, everybody has joined, no? Right. Okay. ठीक है. It's clear, no? एक मेन स्पीकर येईल, हे बाकी के
So good evening, good afternoon. I'm Dr. Sood here. I'm also there.
Good afternoon, sir. How are you?
नितीन,
Good afternoon,
मला
Dr.
ऐकून येते, बोलतायत लोक.
Yeah. Okay. Fine. बघतो. त्याच्यासाठी
Hello, can you please let me know how to put the virtual background? I forgot.
You open your email, you download virtual background.
Or open
And
window.
In the Zoom.
Yeah.
See, have you downloaded your virtual background?
Yes, I downloaded on desktop.
Desktop, good. Then on the Zoom, there is one option at the right bottom, left side.
Left side. Okay, where?
One option of start video.
Yeah.
Just next to that, there is one arrow, upward arrow.
Right.
Click on that arrow. You click on that arrow. Have you clicked on that on there?
Hi everybody. Can we share our screens? Manish, if it's possible.
I can share immediately. It is disabled. Host has disabled sharing. Somebody in
Okay.
he is not allowing me to
Hello.
share.
Hello.
Hello, Preeti. I'm Dr.
Hi.
Bhide.
Hi.
Hi, how are you?
I'm fine. So can we just check the slides because they have disabled sharing?
Rahul, can you do that? Allow everybody to share slides. Rahul?
Yes, sir. Making everyone co-host.
Yes. So that they can share their slides because they are all speakers.
Abhijit, please make the speakers.
Sir, I have already made
Allow everybody to share slides. So if
I am still getting a message that you are not allowed to share.
Dr. Manisha is not able to share his slides.
Yes, sir. In a moment, I am doing that.
Okay, I think now I can. Okay.
I also need to have that ability.
Yes, sir. Just a minute.
So can you see the slides now?
Yes, Manish, it is seen. Properly seen.
So can I check mine, Tilan? Or mine is still host disabled?
Yeah, I can see yours.
Hello. Rahul, please allow everyone to share slides.
Yes. Doing, sir. In a minute.
Yeah.
Yeah.
Hello, Dr. Sood. How are you?
Good afternoon. I'm fine. Nice to see you. Good afternoon, Dr. Nangya. And
Hi, good afternoon, everyone.
Oh, hi, Dr. Nangya.
Hi.
Hi. Hi. Good afternoon, everybody.
I'm sharing my slides to have a look. I'm still disabled.
Okay, I'm also disabled.
Rahul, please allow everyone.
Yes, Abhijit is making changes. So welcome everyone. Abhijit is here to make the technical assistance for everyone. And Abhijit and Sampada, these are the two people are here for making you co-host and allowing you to share your screens.
Hi, Ajit.
Hi,
Hi.
good to see everybody.
I know, yes.
Can I?
Dr. Nangya, you will start introduction. I mean, I
Yes,
tried
okay.
calling Rupali, but I couldn't contact her. So the first three speakers, you can introduce.
here
Then I
only.
think Medha will, and then I can do that.
Preeti,
All
are my
right.
slides
Medha,
visible?
is that all right?
Preeti, can you see my slides?
Hi Raja,
Hi sir, how are you?
बस surviving.
Why surviving sir? क्या बात कर रहे हो आप? Hi.
याच्यामध्ये ते व्यवस्थित दिसत नाही.
हा बरोबर. तो ब्रेक होतो, फेस ब्रेक होतो बऱ्याच वेळा. फेस म्हणजे हात असा वरती केला की काहीतरी असं वेगळं. It's just 2 o'clock, 1400. So let's start.
Yes.
So I, Dr. Preetham Samant, Scientific Chairman, would welcome everyone to this a milestone in the history of Maharashtra Ophthalmological Society, the MOS Virtual Conference First 2020. And we today are the opening batsmen. We are starting the conference. This Hall C, the first session is on the award-winning papers and videos of 2020. I would like to invite my co-chair for this session. I would like to invite Dr. Sunaina Malik Madam, Dr. Parikshit Gopte Sir, Dr. Vardhaman, Dr. Rohit, the Secretary of the Scientific Committee. In a milestone event for MOS, the free papers and videos that were submitted for 2020 were presented and judged live on a virtual platform on last Sunday, 1st November. And they were given marks and scores. And this session today will showcase all those free papers and videos which got leading scores and were highly appreciated by the audience. Now, I have just two instructions before I ask Dr. Rohit to take over. Number one, all those who are with me on as the presenters and the chair people, I would like them to switch off their
Written session, we have with us leading stalwarts from all over India, and it's a covering all the major topics which we deal in our day-to-day OPD practice. It starts from ARMD, diabetes, then infection, then pachychoroid, vascular block, then ROP. So I am sure that by the end of the session, all of us will become richer in our day-to-day practice, listening to all these stalwarts. And we have with us around 90 minutes, and hopefully we should be able to finish in time and with support.
which is removed quickly to prevent collapse of anterior chamber. We routinely use Rifamblue to stain the anterior capsule. To illustrate how visco behaves during various steps of cataract surgery, we deliberately stained a viscoelastic with Rifamblue. Hydrodissection is performed routinely. During nucleus management, first insert the phaco probe with irrigation on and later replace the chopper in left hand. With the phaco energy uses, direct chop was used. Nucleus was divided into fragments and they were emulsified. For irrigation and aspiration, chopper was removed first, which was replaced by irrigation probe, and then the phaco probe was removed. Through the side port, aspiration port was introduced, and then the IA was carried out. After the completion of cortical removal,
PEDs, notched serosanguinous PEDs, or it could be a tall thumb-like PEDs, or classically this double layer sign, separation of the RP from the Bruch's membrane and presence of a hyperreflective tissue between the two layers. So this is also
your paper, your video more statistical. I think you would need to have specular microscopy so that there can be a definite difference seen between cases done with your method and the other method.
When when we are playing or the person is talking, so that will give us a crisp audio. Thank you.
Is the screen visible?
Yes.
Yes.
One second. So sorry. Fatima, you are present in the meeting, right? So I will move these slides. You can give the voiceover because your voiceover is not functional.
Yes. Yeah.
Okay.
Is she there? Dr. Fatima is there?
Yeah, I can see her. Fatima, can you unmute yourself? Okay, we are not able to connect to Dr. Fatima. We'll move on to the Fatima, you're there?
See her. If that is her. F.
Yeah. Hi. She's there. Yeah.
Good afternoon. Yeah. So you can give the give the voiceover yourself and tell next so that Dr. Rohit can move the.
Yes, sir. Okay. Good afternoon, everyone. Myself, Dr. Fatima Noble. Thank you,
I think we'll manage. Please do not.
Type 1, it's a type 1 or occult CNVM. So here we look at another 50-year-old man who has defective vision. Look at the large subfoveal irregular PED. Here you see the sub-RP reflectivity and the pre-RP reflectivity.
Next slide. So can you just play the animation?
Yeah, it just give me a...
The foreign body had a good visual outcome than the patient who had a non-metallic foreign body. And size of the foreign body patients who had a foreign body more than 4 mm had a poor visual prognosis than the ones having a foreign body less than 4 mm. All the cases were associated with 100% endophthalmitis, 53.3% had cataract, and 69.2% had corneal tear. So coming to the time interval between the trauma and surgical intervention, it was earlier thought the more early you do a surgery for intraocular foreign body, the better will be the prognosis because you are avoiding endophthalmitis. But now it has been studied that if it's a metallic foreign body and if you delay it for some time, it will reduce inflammation and you can handle it well. So there is a controversy in this. Coming to the visual outcome, the overall logMAR improved basically after intraocular foreign body removal. So next slide. In our study, it was found out that the young male industrial workers were at the greater risk in this study, and the outcomes depended upon the size of intraocular foreign body, the site of lodgement, the entry wound, the endophthalmitis, and type of intraocular foreign body, with non-metallic having a worse visual prognosis. So basically, this study helped in finding out the severity of trauma, determining an appropriate treatment for the patient, and predict the visual prognosis. Thank you.
Very nicely elucidating the imaging in ARMD. Can you stop sharing for a while? So, any questions by anybody? Or you see, this thing was, do you do FA at all nowadays? In ARMD?
We actually do light-based
Voice is breaking up. Yeah.
We do light-based angiography in two situations, either we are suspecting an PCV or
I think something is happening to the, I don't know. Everybody can hear clearly?
No, it's breaking up. But what he said was dye-based angiography does in PCV or in RAP lesion. That's what he has mentioned.
Yeah.
But his voice is breaking.
Yeah, voice was breaking up.
Yeah, I agree. I think by and large, the usage of FA has reduced drastically in management of ARMD. You see, very rarely, if at all, ICG we definitely do. Like today also I had to do one ICG, but that lady, whatever I did today, had multiple polyps. Polyp, although you can suspect on the other imaging modality, but for confirmation specifically.
It is defined as a full thickness defect in the neural retina, concentric on the fovea. Based on OCT, modified gas classification shows stage 1A, small central yellow spot, 1B, yellow ring with loss of foveal depression, stage 2, showing small full thickness macular hole of The first successful macular hole surgery was published by Kelly and Wendell in 1991. These are the basic steps in a macular hole surgery. After core vitrectomy, PVD induction is done, which is important to reduce traction on the macular hole. ILM is stained to ensure proper peeling using dyes like brilliant blue, Triffin blue, and indocyanine green. In the pinch technique, ILM is pinched with forceps and gently pulled away from the macular hole margin. In flip the flap technique, a small incision is given over the ILM away from the macular hole margin. Then the ILM is held with the forceps and pulled as a flap. In conventional peeling, the ILM is peeled centrifugally as a tangential vector, regrasping the ILM every few degrees of the peel.
Sequentially, every year, 2015, 2016, 2017, and then in 2018 and 19. So what does this tell you?
With autologous blood application and absorbable macular plug can be used. In case of simultaneous retinal detachment of macular hole, utmost care should be taken to stabilize the retina. This can be achieved by injecting PFCL prior to ILM staining. In addition, PFCL also prevents the dye from gaining access to the subretinal space. If we are unable to use PFCL, the dye can be injected away from the macular hole.
We have Dr. Santosh Agarwal here with us. I can see him. Santosh sir, any comments on that? Dr. Santosh Agarwal, very accomplished retinal surgeon with a lot of innovative techniques he comes up with. Santosh sir, your comments?
Yeah, it's an excellent video. I actually last few techniques I could see, and it's really brilliant view. Is very amazing. It gives staining, and we can perform in a whatever way you are comfortable with the technique. And I think inverse flap technique is very good technique. And I have no experience with the capsular piece or any other method, but whatever I am doing, I got excellent result with that.
Thank you, thank you. Shall we proceed then, Rohit?
Absolutely.
Thank you, Dr. Sumitra. Thank you for the presentation. Let's proceed.
Thank you, sir.
Yeah, I welcome Dr. Prashant Babankoe, sir. He has just joined us. Welcome,
So the next we have a retrospective multifactorial study of pediatric infectious and non-infectious keratitis in South India by Dr. Abhijit Tagare.
Dr. Jagannath Buramani sir has joined us on the panel. Welcome, Dr. Buramani sir.
Macular ischemia, there was no increase in macular ischemia, which was proven in many other trials. Then the next question is which injection to choose. Let's not go into the names, the title, the topic. This protocol T is about comparing bevacizumab, ranibizumab, and aflibercept. Basically, Avastin, Lucentis, or Excentrix, and Eylea. Which one is better? So in this protocol, again, what you see is patients who have less than 612 vision or 20/50 vision. Their
proliferative vitreoretinopathy equal to or more than C1 with coexisting macular hole using different management strategies. Patient underwent standard study. This is a prospective non-randomized observation.
She had a best corrected visual acuity of 6.6 and N6 in both eyes. Applanation pressure correlated with the corneal thickness were 12 and 13 millimeters of mercury. And you can actually see what the front of the eye looked like. The anterior segment appeared normal and the discs were also normal. So here was the dilemma that this was this lady, 50-year-old, not using a presbyopic correction, having discomfort or headache when she was doing near work, and on lubricating eye drops. Intraocular pressures had never been on the higher side, and the disc was normal. So we didn't think in terms of getting the visual fields done because it was just a simple headache that she had come for. And now we did a gonioscopy, and I'll come back and tell you why we did the gonioscopy. Because when we saw the inferior angle in the superior
at 1 month in various groups are demonstrated here. So to conclude, better macular hole closure and attachment rates can be achieved with inverted ILM flap technique. Visual acuity gain is seen more in inverted ILM peel group compared to no peel group. Though challenging and not free of complications, inverted ILM peel can be considered as a procedure of choice in these cases. The limitation of our study is that it has a small sample group. Definitely large randomized study.
Hello.
That was a great free paper. Thank you, Dr. Prashant.
Thank you. Yeah.
Let's move on to the next one. Rohit, which one do we have next now?
So the next we have a wonderful video by Dr. Santosh Agarwal of an innovative phaco joint.
Okay. Again, for all our audience and panelists, I would like to say that these are all videos and free papers which made a great impact on last Sunday on our judges and our the people who attended. But we are still in the process of computing the marks and scores, because there are total of 13 categories under which we will be giving the awards for these free papers and videos. So we will take a day or two more to actually compute the scores and come up with the awards. Yeah, please go ahead. Rohit, start.
I am Dr. Santosh Agrawal. I am going to present the video on an innovative visco chopper through which the visco can be delivered inside the entry chamber. It acts as a two-way function. One, it acts as a chopper and also as a visco delivery system. So this is applied to the silicone oil port or the vitrectomy port on the console, and the silicone oil system is used for this purpose. Instead of silicone oil, we use visco, and this is the knob on the foot pedal which is given by the company for activation of this port. You can see the VAPI port on the console, which is specially made for this purpose by TurboVit Appasamim the visco through a automated visco delivery system. So we can take out the fluid cortex, at the same time we can inject the visco. Now this is the PC rent which has taken place, and to avoid the extension of the PC rent, we can inject the visco inside the entry chamber through this chopper, so that the entry chamber depth is maintained, IOP is maintained, and the visco will take care of PC rent and the vitreous. Now this is the small pupil. Again, it is very difficult to perform the CCC, so visco can be delivered and you can have CCC with ease. This is another case of hypermature cataract challenging situation. Here I used AC maintainer to deliver the visco. It can maintain the entry chamber, and you can extract the fluid cortex, the liquid cortex, through the main incision or through the extractor. This is another challenging situation where the last piece of the nucleus, while removing you need good AC depth, otherwise PC rent can happen. This is another challenging case of lens-induced glaucoma case. Corneal edema is there, iris is coming out through the wound, lot of IOP pressure in spite of all measures. We have taken anti-glaucoma measures. So this visco inside the entry chamber can give you protection from the endothelial damage. This is another scleral fixation IOL case where a lot of manipulation is required.
Questions from the last few slides, I was more fascinated. Whether do you agree that you see seeing those slides of macular hole and a cataract surgeon injecting a 22 gauge needle straight into the vitreous cavity rather than a two-level incision. Do you at VRC advocate any comprehensive ophthalmologist giving these injections?
So as of
in complicated phaco cases or hard cataract cases where we need endothelial protection, in such cases, or to avoid PC rent and to have a good depth of AC, I think this is the most rewarding technique. And also many cases, if you get a PC rent, if you take out your phaco probe, you get extension of the PC rent. But
OCT angiography versus structural OCT. Myself, Dr. Shruti Ladha from Shanti Saroj Netralaya, Meerut. As we all know, OCT angiography is a novel, non-invasive technology that rapidly images the blood vessels in vivo. Studies have shown that OCT angio is the purpose of our study is to determine the ability of structural OCT versus the ability of OCT angiography in documenting the treatment response to anti-VEGF injection in wet AMD patients. We conducted a retrospective study in which 40 eyes were recruited over a period of 10 months. Heidelberg Spectralis was used for both OCT angio and structural OCT. 40 treatment navies with active CNVM wet AMD was selected. Baseline OCT angio and structural OCT were done for all these patients. 3 intravitreal anti-VEGF bevacizumab were given monthly. And monthly monitoring of treatment response by OCT angio and structural OCT was done for all these patients. For evaluation of treatment response, structural OCT criteria were reduction in subretinal and intraretinal fluid, reduction in height of PED, reduction in number of hyperreflective spots. The above image is of structural OCT prior to giving anti-VEGF injection, where we can see there is evident intraretinal and subretinal fluid, subretinal hyperreflective material, and the CNV complex. The below image is of 1 month after giving anti-VEGF injection, where there is evident reduction in intraretinal and subretinal fluid, reduction in the subretinal hyperreflective material, thus reduction in CNV activity. OCT angio criteria for treatment response interpretation, example associated hypertensive or diabetic retinopathy, inability to capture a good quality image, example in macular hemorrhage. We found that structural OCT detected signs of treatment response in 36 out of 40 eyes, that is 90% cases. Whereas OCT angio detected signs of treatment response in 37 out of 40 eyes, that is 92.5% cases, which is almost similar. Statistical analysis showed that there is no significant difference in the ability of structural OCT and the ability of OCT angiography in documenting the treatment response to anti-VEGF therapy. So coming to discussion, here we can see in recent year, few studies published in some established journals have emphasized that OCT angio is a very important tool for monitoring the treatment response. But none of these studies have simultaneously compared OCT angio and structural OCT. In our study, with comparatively larger sample size, we found that there is no significant difference in OCT angio and structural OCT in documenting the treatment response to anti-VEGF therapy. So the conclusion of our study, though OCT angio was more sensitive compared to structural OCT for documenting the treatment response to anti-VEGF injection, the difference in sensitivity was not statistical.
Or intraluminal and interstitial pressure rise, leading to retinal ischemia, which leads to this VEGF increased production. Now, this upregulated VEGF production leads to retinal ischemia, causing capillary leakage, leading to macular edema on one hand, or a neovascularization either in the anterior or posterior segment or combined, and ultimately leading on the most morbid neovascular glaucoma. So CRVO, as we know, they're a major sight-threatening complication, and ranges in prevalence from 0.04 to 0.5%. Can be ischemic or non-ischemic. Non-ischemic, where the site of occlusion is distal to the lamina cribrosa or the adjacent retinal region. In ischemic CRVOs, more often the site of occlusion is in the region of the lamina cribrosa or immediately posterior. Coming on to evidence for management, the prime mover for anti-VEGF therapy, prime evidence, came from ranibizumab trials. And BRVO and CRVO, they had parallel trials called Bravo for BRVO and Cruise for CRVO, which were initial 6 months of monthly anti-VEGF versus sham, and then they went on to PRN for the next 6 months. These patients were then continued. That was a good thing they did. They continued to follow them up to the horizon to see if there was a longer term effect of horizon, and then they continued them further for 4 years with the
emulsify the instruments. On the right hand side is a regular chopper, and this is a slicer like a sickle, horizontally oriented. Soft cataracts pose a special problem as it is difficult to form fragments to the phaco tip, thus preventing chasing of the nuclear fragments, keeping the probe all the time in the center. This horizontal slicing protects the endothelium and the posterior capsule, as you can see here. Next, we present a posterior polar type cataract. Here, it is again difficult to chop the fragile nucleus. After the CCC, we do a gentle hydro delineation as seen here by the golden ring. As you cannot rotate the nucleus, the central portion is first tackled and then gradually we move towards the mid-peripheral nuclear portion, finally the epinuclear part, and then once the whole nucleus and the central hard core is sliced and emulsified. Here you see the second half of the nucleus being sliced and emulsified piece by piece. Notice how the slicer holds back the piece in the bag, protecting the posterior capsule all the time. We need not change the parameters for the last piece.
Similar robust designs were there. Aflibercept 2 milligrams 4 weekly versus sham. Then you go down the line. I won't delve into it. What was very interesting and what was very creditable in this group of studies was that these were at that time the only phase 3 anti-angiogenic trials to include non-perfused patients. Very often the criticism that came up in conferences and other meets were that, you know, people, when they design a large trial, they would put in that much of effort, but they would just skip the ischemic patients. They would only include the non-ischemic patients to boost up their, final equities. But this study bravely put up
firmly into the capsular bag till the end of the procedure. See the ease with which the fragments are being sliced requires very minimal energy, which is friendly to the endothelium.
Thank you very much for sharing the amazing technique.
Thank you, Amos.
So next we have Dr. Abhijit Tagare online. I would request Dr. Abhijit to give a voiceover for his presentation. I will be sharing the presentation from my side.
Hello, sir.
Is the presentation seen, sir?
Yes, we can see it, Rohit.
Yeah, please.
We can see it. Yeah. Hello, Dr. Abhijit.
Yeah, hello, sir.
Respected everyone, myself Dr. Priyanka Kanekar and my paper topic is study of efficacy of revamifide 2% and carboxymethyl cellulose 0.5% eye drop in dry eye cases, co-authored by Dr. Rupa Naik and Dr. Siddharth Sane. Background and objectives. Dry eye disease is a tear film disorder which causes ocular symptoms like foreign body sensation, dryness, blurring of vision, photophobia and tear film dysfunction. The prevalence in India is 29.25%. The primary causative reasons of dry eye are lack of tear production or increased tear evaporation which causes deterioration of the ocular surface and is associated.
Just an illustrative, if you catch case early enough, there's benefit to be had. Multiple injections of ranibizumab, you can see that the contour almost comes back to normal. And another case which shows that, you know, a refractory case of Avastin can be treated with Accentrix and improve significantly. So the enigma of hemi-RVO, so this is something that we don't see that often, but there's always this doubt whether to call hemi-CRVO as a hemi-central RVO or a hemispheric RVO. So when the patient has an occlusion of one of the trunks in a patient who has a dual trunked CRV, which persists at the anterior ONH. This is a congenital variant that is seen in up to 20.3% of hemi-RVOs. That kind of patient will present more as a CRVO. On the other hand, the hemispheric RVO is where you have a major branch of the CRV which is blocked at or near the optic disc. So it comes out of the optic disc as one and then branches out. Then if there is a block to one of these branches, those will present more as a BRVO. So in terms of natural history, the clinical features of CRVO in both HCRVO in both the acute and the chronic phase seem to more often resemble CRVOs. 85% of the HCRVOs are non-ischemic, and that statistic is quite similar to that of CRVOs, where you have a greater percentage of non-ischemic CRVOs than ischemic CRVOs. It's the contrary in BRVOs, where you have
function by tears and breakup time, tear secretion, Sturmer's 1 and Sturmer's 2 test, slit lamp examination of tear meniscus height, and IOP measurement by Goldman's applanation tonometer. Follow-up: patients were assessed at 4, 8, and 12 weeks. Results and observations. Table 1 shows demographic data. There was no significant difference between the two groups since the p-value is more than 0.05. Comparison of mean Sturmer score. In the follow-up period after treatment with drugs at 4 weeks, there was no significant difference in the mean Sturmer's test score between rebamipide and CMC groups. In both the groups, Sturmer's test was found to increase gradually from 4 weeks to 12 weeks after initiating the treatment compared with the baseline, and significant changes were seen in Sturmer's test score 4 weeks after the treatment, although there was no significant difference at 2 weeks. Similarly, S-Kinoshita observed significant difference at 4 weeks between rebamipide 2% and placebo groups. In our study, a significant difference of mean Sturmer's and tears and breakup time score between 2% rebamipide and 0.5% CMC groups was observed at 8 and 12 weeks. It suggests that rebamipide 2% eye drop improves the tear production and quality in dry eye patients by increasing the mucin production from droplet cells. The reported adverse effects were similar between the two groups. However, there are few constraints to the current.
So next speaker, I think I'm going to introduce Dr. Ajit Hazare, and he's a leading glaucoma specialist from Aurangabad. He's going to take us on PG medications in glaucoma and what is new normal. After this, he's going to present with a case also, a very interesting case. So to over Dr. Ajit Hazare.
Yes, good afternoon, everyone. And I thank MOS and
masking the unsightly lenticular opacity.
This 26-year-old male presented to us for the cosmetic improvement with a complicated mature cataract in a blind eye. Doing a cataract surgery in this eye, initially we separated the corneal lamellae with the help of knife, followed by the corneal lamellar separator, which we use in a case of corneal lamellar surgeries. A blunt dissection in a slow manner is needed here, as the patient was not having a very adequate intraocular pressure. A circular corneal pocket made all over the unsightly lenticular opacity. The care is taken to cover the opacity all around and make it a circular one. The candle soot is collected with the help of 2 burning candles and the steel pot. This is a very easy method and you get ample of soot. The soot is then collected with the help of a tissue paper and is then used for the intrastromal lenticular opacity. Doing this extraocular surgery in a blind eye with lot of intraocular issues have avoided many intraocular complications like hyphema, risk of having a white reflex after surgery. The corneal pocket or the corneal flap is then closed with a 10-0 interrupted suture so that the soot remains in the corneal pocket and doesn't fade with the time. This is a very simple surgery and it helped tremendously to improve the appearance of a young patient after closing the corneal lip with the of 10-0 suture. The excess of soot then is washed
With corneal tattooing. Sir, you can unmute yourself.
Yeah. Can you hear me now?
Yes, I can.
Yeah. I couldn't understand your question. Please repeat.
Yeah. So how do you compare this technique with corneal tattooing?
Actually, this is one of the type of intrastromal corneal tattooing, and the another form would be doing a multiple stromal puncture and using the India ink sort of thing, right?
Right.
But doing the multiple stromal puncture in the center would not have given me the circular shape, the first thing, and it might not be a very uniform pigmentation there, right? And the chance of fading with the time is more with the intrastromal the multiple stromal puncture technique than the intrastromal soup technique.
Really appreciate your innovative and cost-effective way of helping the patient.
Yeah, in some eyes, when the intraocular pressure is not adequate, there may be some problem while doing the pocket, and so when that situation, you can try doing a multiple stromal puncture with the India ink technique.
Yeah. Thank you for your inputs. So next, we are going to have Dr. Tagare, who will present his work on infectious keratitis.
Wonderful presentation, Dr. Praveen. Thank you.
Thank you, Pritam.
And Rohit, how many now do we have left remaining?
We just have a couple of free papers. We are on time, sir.
Okay, great, super. And then you can show another one.
Sure, I'll do that. We have Dr. Anjali Singh.
Yeah, she's here. I can see her on the board.
Yeah. Descriptive analysis of allergic etiology of keratoconus. Just give me a second.
Yeah.
Hello.
Yeah. So, Dr. Anjali, can you give the voiceover? I will move on with the slides.
Dr. Shivraj, will come to your presentation after this, if you don't mind.
Sir. Yes.
Dr. Anjali, I am again starting the presentation. Please give the voiceover.
Yes, sir.
Please start, Dr. Anjali.
Wait, your screen is still not sharing, Rohit. It's still.
It's not. Okay, sorry. I'll just reach.
Yeah.
Is it seen now?
No.
Ultimately disturbs corneal stroma and causes thinning and ultimately keratoconus. Next. So now it's a well-established fact that keratoconus is related with allergic conjunctivitis. So why we conducted this study? So our purpose was to find out which factor of allergic conjunctivitis is related more with the keratoconus. Next. So we wanted to study the correlation between severity of allergic conjunctivitis. So it was a cross-sectional sectional study. The inclusion criteria was signs and symptoms suggestive of allergic eye disease and age group of 4 to 30 years. And exclusion criteria was any other type of conjunctivitis with age less than 4 or more than 30. So how we conducted this study, we examined total 200 eyes. A detailed clinical history was taken. Best corrected visual acuity was done. Detailed clinical examination was done. Slit lamp microscopy, keratometry, video keratography, and Amsler chromic criteria was used to grade keratoconus. Next. Next. So here are the results.
Okay, fine. Thank you, Dr. Swapnesh, Dr. Manish, and Dr. Preetam for this opportunity to present in this meeting, and thank you for the invitation. Obviously, I cannot cover all the pediatric retinal disorders in about 8 minutes time, so I'll just limit myself to surgical disorders.
Hello, can you hear? I can't hear actually.
So we can hear.
Can you hear me?
We can hear, sir.
We can hear. Please.
Okay, fine. Sure. So we'll start with some of the disorders which we come across in routine clinical practice. One of the commonest is persistent hypoplastic primary vitreous. PHPV is usually unilateral and the eye can be visibly small, or it can be very subtle that we need to do a biometry to see if the eye is small. How they present is they present with a posted.
Yes, sir. Hello?
Yeah, okay. Let's start.
Is the screen visible?
Yes.
Dr. Shivraj, please start.
Good evening, everyone. So today I'll be talking about my study about infectious
site of anterior perforation. Similar site of fibroscular proliferation we will see when there is a globe rupture as well. So once the retinectomy is done and the retina is reattached, and we do laser photocoagulation and oil. Another trauma which doesn't involve the eye can be Terson syndrome. So this is usually following a head trauma, and this is a sub-ILM bleed over the macula. Most often it's bilateral. And
compared to non-infective keratitis, which was about 6.8%. Next. Going on to this associated risk factor, it was found that most
everything was done for including all the blood tests and all.
MRI with contrast. So the important thing is that in the end, always be with contrast. So these are things, if everything else remains the same, I would not call this progressive. That is one. Even though there is, I would still say there's fluctuation because perhaps my experience is a little longer, so as compared to
sensory amblyopia, as this scar was in about the the critical period. So it is very necessary in order to diagnose the patients as early as possible, as diagnosing early and treating early will always lead to a favorable anatomical outcome and decrease the probability of having scar, and hence the profitable or better visual outcome as well as anatomical outcome for the children. So it was found a maximum number of patients healed with medical treatment, and other surgical modalities were rarely involved in this study.
Can we now go into Dr. Rupali's, because we don't have too much time? Can we go to Dr. Rupali's case and we can discuss that also? Rupali, are you connected? I think
she's there.
Yes.
No, she's not able.
We go on to the next session, which is strabismus. I think I'm chairing that session, so I think I can see the first speaker already there. Thank you so much, Rohit, for being with us. We still have 1 minute to go, I think.
Hi, madam. How are you?
Hi, Hema. Nice to see you.
Hi, Dr. Uday.
Uday, nice to see you too. Shall we start? If we can start early, why not? Uday is there.
We have 2 minutes actually.
We still have 2 minutes, I know. But
Abha Kanade, ma'am is here.
Which is expected from all of you. Thank you.
Uday, are you ready?
Uday, unmute yourself.
No more presentations.
Actually,
I'm not very well versed with this thing. I'm searching for my presentation to share.
It's okay.
Presentation share करायचं मला. Screen share करायची.
Uday, share your screen. Share your screen.
Yeah. One sec, ma'am. Share. Screen share करा.
No, but first of all, keep your presentation on your desktop, on the screen of your laptop.
I had done that, but I thought
now share screen. Click on share screen. It'll open. It should open. Go on the green button and do share screen. No, you are not. You haven't done it. Click on the green button at the bottom.
At the bottom, there is no green button.
Are you logging in from your mobile? Or from there has to be a green button. If you are
No,
in Zoom.
I am logging in from my laptop, from the link which has been given by the mail.
That's okay. So the link is correct.
You are there in the meeting. The link is correct. There's a button at the bottom. Just see a green.
Uday doesn't know how to link it.
Host has disabled participant screen sharing. That's what coming.
Okay, Pritam.
Should we go into the next talk or should I help Uday?
Good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. Today, my topic is refraction in the child, which can be quite challenging as children do not cooperate, their attention span is less, and strong accommodation accommodation plays a role. Accuracy is very important because many a times we have to give objective correction. So today I aim to solve the few questions like who should undergo refraction, when should the refraction be done, how should it be done, which is the right cycloplegic agent to be used, how much is the refractive error, how do we calculate that, and then how do we decide does this child need these glasses.
An elderly male who's been followed up by us from the year 2002. And if you see the fundus picture, is typical of chronic central serous retinopathy with widespread pigment epithelial disturbances and something in the papillomacular bundle of the left eye. This was his fundus fluorescein angiogram. You see the speckled fluorescence in the right eye. You see the leaky choroid here. You see the leaky choroidal vessels around the posterior pole. And you see the structural OCT showing very dilated large choroidal vessels or pachyvessels.
In children more than 5 years of age, with or without any strabismus, especially esotropia, you can use either atropine 1% eye ointment, cyclopentolate eye drops, or home atropine eye drops. But atropine can be quite cumbersome in children because it can, especially in the school-going age group. So a common regimen which can be used in older children is cyclopentolate 1% or home atropine 2%, 1 drop 15 minutes apart, followed by a drop of commercially available combination of tropicamide and phenylephrine.
Features the sharp peaked PED, the notched pigment epithelial detachment, and a hyperreflective ring underneath the pigment epithelial detachment were believed to be sufficient findings suggestive of PCV diagnosis, and any three of these were believed to be sufficient to make a diagnosis without the presence of ICG angiography. Now, this is a patient.
Diopters. If there's a refractive accommodative esotropia with normal AC by A ratio, you have to give full hypermetropic correction. With high AC by A ratio, executive bifocals with or without distant correction as needed are given. Taking
A is best for branching vascular networks, and this is what we see here in this slide. You can't see the polyp on OCTA because it's a very low flow lesion, but you see it well on ICG angiogram. The vascular network is seen very well on the OCTA.
This is myopia management. With the increasing incidence and prevalence of myopia, we should not only, if we cannot prevent the onset, we should at least try to control the progress of myopia. This includes some advice regarding reduced screen time and time spent on indoor activities, as well as increasing the outdoor activities. Up till now, we have been giving optical correction only for the in the form of single vision lenses to improve the vision. But nowadays, there are options available in the optical correction in the form of executive bifocal lenses, peripheral defocus lenses.
Followed from the year 2019, he had a large scar at the macula in the right eye and what looked like an occult choroidal neovascular membrane in the left eye. And 6 years down the line, he developed a peripapillary CNVM nasal to the disc and persistent recurrent fluid in the left eye.
For maybe 2 hours before they come to you. And when they come to you, add a drop of P+, and it works. Then the pupil dilates actually. Otherwise, it doesn't. And the homide has already done its work. So
that's the snap. Okay. So let's watch that again in action replay. Now you notice I'm doing the hydrodissection to the side for bad eye. That's the snap. Because it's such a closed chamber, you get much higher pressure. Hence you get the. At that time, I didn't know what had happened. I knew something had happened. As I proceeded with the phaco, I could see that the nucleus started tilting. Once the nucleus started tilting, I knew that I had had a posterior capsule rupture. And then I used a vectis to deliver the nucleus, having enlarged the wound first. If there's anything good about the hydrorupture of the posterior capsule, I would.
The conjugate binocular movements, that is versions, followed by uniocular eye movements, that is ductions, are to be tested in all the 9 diagnostic gaze positions. These 6 cardinal gaze positions, we test one muscle from each eye, which is predominantly responsible for that movement. Superior rectus, lateral rectus, and inferior rectus, they are tested in abduction. So diagnostic positions for these 3 muscles is extraocular muscles is of abduction, and for superior oblique, medial rectus, and inferior oblique, rectus is acting normally. If not like that, then it's a underaction. The next most common muscle to overact is inferior oblique, and it is tested in dextro elevation for the left eye and levo elevation for the right eye. The elevation in the adducting eye is noted. If it is more than that of the other eye, then inferior obliques is said to be overacting. Inferior oblique overaction leads to V pattern. That is, as can be seen in this, that exotropia is increasing as the upgaze is increasing. So one thing to be always remembered is exo more in up is V, and from this single you can derive all the other patterns which can be there. So inferior oblique overaction can be graded as 1+, 2+, 3+, and 4+, depending on the angle which the tangential lines passing through the pupillary centers of both eyes make. Now in this case, the elevation in the abduction appears to be okay. In elevation also it is okay, but in adduction there is complete absence of elevation, and this typically happens in Brown syndrome. Superior oblique action is tested in the adducting eye in the depression, like in the dextro depression and in levo depression. If the adducting eye is depressed more as compared to the other eye, it is superior oblique overaction, and superior oblique overaction leads to a pattern, as can be seen that exotropia in the right eye is completely normal, but the left eye is not adducting completely. Actually, it was a case of slip medial rectus muscle, and I had to explore and re-advance the medial rectus to its original place. That took care of her exotropia. This is routine third nerve palsy with total ptosis and limited elevation, depression, and adduction of the right eye. This is an interesting patient, young patient who presented diplopia and had signs suggestive of partial third nerve palsy. On imaging, she had thickening of the nerve was quite consistent with hemiplegic migraine, which she responded well with treatment. The change in the interpalpebral fissure height has to be also noted, so that it gives us clue towards the diagnosis, like narrowing on adduction and widening on abduction points towards DRS. In this child, look how her eye downshoots and upshoots. This is again typical of DRS. If patient is presenting with ptosis, pseudotosis has to be ruled out, because sometimes doing only squint surgery might be satisfactory for the patient, because only squint surgery can make the eye fixing, and his or her ptosis can reduce. So next important
coming into a great thing nowadays, because children are born, they survive well. So we have a lot of children who have disease in zone 1 or posterior zone 2 with very low gestational ages. They may have iris new vessels, they will have rapid progression, and they have very dilated tortuous vessels in the posterior pole.
The amount of prism strength which is required to offset all movements of red rays gives us the measurement of the squint. Points to remember here are measurement should be done for near, distant, and all diagnostic positions. We have to neutralize horizontal first and then vertical. Cyclovertical, we have to do 3-step test, but the fallacy with this is that it is suitable and accurate only in recent onset palsies. So these are the 3 questions we need to address. In long-time standing squints, in restrictive squints, status post-trauma, and in paralytic squints, sometimes we have to do post-duction test, which can be done after appropriate anesthesia in OP in adults, but for kids, it has to be done in OR only. Regarding Hess charting, it's more of a prognostic value than diagnostic value. It can be serially done in patients with restrictive strabismus or paralytic patients to know what difference it has been done. So to summarize, proper motor evaluation, proper surgical planning as well execution leads to happy patients as well as happy surgeon. Thank you very much.
Thank you. Thank you, Dr. Uday, for this fantastic presentation. You made cover test look so easy. Most of the times it's the postgraduates who who are very scared when they see a squint case, but you've explained it really nicely, the basic examination. Nipa, you have any questions? Dr. Nipa?
Yes, may I?
Yeah, sure. In the meanwhile, may I ask the next presenter to be ready with her presentation while Nipa takes the question? Dr. Zai?
Nice presentation. It covered everything. I have a few questions. For your
video,
it doesn't matter. Go ahead.
I think this is a case-to-case decision. Like for -1/2 or -1, when we have to do it, like especially in cases of this question comes mostly when there is palsy, especially 6th nerve palsy patients. Yeah, definitely. If in 6th nerve palsy, if it's a paralytic condition, then -1/2 or even -1 would be taken care by recess resect. But if it's more than that, we have to do some other procedures like transposition procedures and all. And regarding the overacting muscles, it is most commonly in obliques, especially in inferior obliques, that 1+, 2+, 3+, 4+ overgrading is most commonly done. And I usually do weakening in inferior obliques if they are 2+ or more.
Okay, I was just, yes, that's very nice. I'm just looking for consistency in recording. So do all of us record 0 to 4 as a scale for under and overaction, so that when we see patients after some time, or if we see each other's patients, we are all consistent in is that some recording system that we all follow? Do you follow the 0 to 4?
Actually, this should be universal. Actually, most of the times recording of all these underaction and overactions are done subjectively. Even when we started doing this, we categorically started noting 1+ as 1+, 2+ as 2+. But what I have personally noted that over the time, our 2+ maybe 3+ sometimes. Just
I would like to conduct the next session. I can already see Dr. Amit Porwal here. Welcome. Dr.
Hi,
Amit.
Pritam.
Welcome, Dr. Devendra, Dr. Akshay, Dr. Anupam, Dr. Mukesh. My apologies for handing over the session late, but we'll do the best we can. Please start. Please go ahead.
Yeah, sure. First of all, I would like to thank our Chairman of Scientific Committee, our President and Secretary for giving us the opportunity at the last moment to conduct the Maharashtra UC session. That was really kind on their part, because all these sessions were packed up and still we could get time for UC. That's great. So we'll start immediately. First, I would like to invite our dynamic Dr. Devendra Venkatramani on how to prepare for FRCS and FICO.
Progression to constant exotropia, and then you can have some hope of restoration of the bifoveal fixation. In most adult patients, surgery can only help to achieve orthotropia, but not the bifoveal fixation. The Newcastle Control Score is a useful measure of clinical severity, and there are some enthusiastic parents, and if you can involve them in assessing how many times the child is squinting in a day, and coupled with whatever you are seeing in your clinic, definitely helps in assessing the improvement or deterioration, and is a useful tool for management of patients of intermittent exotropia.
We decided to operate him. And then first I had to check if I can push it back and get into get the lens into the center. I was worried about that fibrosis, but as luck should have it, the lens could easily come in. So what I did was use 9/0 suture, threaded it through that eyelet, and fixed the lens back in position. And what I couldn't do at that time, I managed to do it now. And his pupilloplasty was done, and I was amazed, and patient was very happy. On the 3rd week,
their near deviation with 1 hour of monocular occlusion. So surgery then should be performed for the largest angle which is measured. Otherwise, the patient is going to have a residual exotropia, and that is going to be manifest after your surgery. Kushner also further subdivided Burian's classification of the divergence excess by an excess of divergence or excessive accommodative convergence. So they believed that these patients really had a near deviation that equaled the distance deviation, but it was masked by fusional divergences at near. So they recommended that they be treated as the basic type of exotropia. That means in these patients, it is recommended surgical intervention before 2 years of age have also been reported by some authors. The increase in tropia phase, this is what happens in many cases of intermittent when they are start decompensating from an intermittent phase to going towards constancy. So that's an important indication for therapeutic intervention. That is, the tropia phase is increasing. We also obviously means that the fusional control is deteriorating. So the progression should be monitored by documenting the size of deviation, the duration of manifest deviation, and the ease of regaining fusion after dissociation from the cover-uncover test. If the patient is taking long to recover from the not recovering the fusion after the cover-uncover, obviously that it points towards the increase in tropia phase.
Go gently. And all the time, be watchful of your phaco parameters. After that, I inject endocapsular ring. There's a definite technique for endocapsular ring when you have too much of a zonular loss. You can use your chopper. And here what I do is I use a safety suture at the end of it on the
Coming to the fees for the ICO, these are appear to be expensive, but I strongly recommend anyone who is considering writing these examinations to team up with at least one other person, because the
surgery with preoperative, orthoptic and occlusion therapy has the highest success rate. So it was more effective in reducing the exodeviation compared with surgery alone. So always give a trial of orthoptic exercises before taking up the patient for surgery. Strabismus surgery can help to preserve or restore the binocular vision in intermittent exotropes. Children receiving the surgery at young ages develop better post-operative binocular vision, and post-operative synoptophoric exercise.
Because of Corona, we have not been able to have it in person or in a hands-on manner, but these are some of the images from previous courses where you can see we have hands-on training and didactic lectures with actual patients. So it sort of mimics or replicates the examination setting itself. I thank everyone for the opportunity and everyone for listening. This is my email address, and I welcome any questions anybody may have, and we could always correspond on email. Thank you so much for your hearing.
Thanks, Devendra, for a wonderful presentation. In fact, Devendra was quite helpful when I had called him before my FRCS practicals, and his certain tips really helped me. So I would really recommend, people who are planning to give their FRCS.
Exotropia is something that is recommended for the long-term success of intermittent exotropia correction. Is that something that you do in most of your patients?
that will
Esotropia post-operative?
Okay, if the patient is less than 5 years of age, maybe I will attempt a slight residual esotropia of about 10 prism diopters, not more than that. Because as the child will grow with the growth of orbits and the eyes will start deviating outwards, I would expect an orthophoria to be gained by around 8 to 10 years of age. But if the patient is already 12 or 15 years.
Sumita, unmute yourself.
Yeah, I'm unmuted. It looks like unmute only.
Yes, you're unmuted.
You wanted to say something?
No, I just wanted to say that.
Should we start?
So my personal experience with IDS has been, I've always been very conservative when it comes to a IDS patient. I kind of observe them, give them a lot of patching, correct the refractive error. And in my own personal experience, the longer you wait, the later you operate, the better are the results.
Yes. No, I just wanted to say I don't blame him. Pencil push-ups are very, very boring. No.
We can start with your talk, Sumita.
Size and how to compartmentalize your theater into different zones. What are the basic concepts to be kept in mind while designing those things? And of course, designing of the main operation theater. In a short overview, not going into details, but whatever is important to be known, I'll try to cover. So sizing is a very subjective thing because everyone will not have the same amount of luxury or space available with them. So it's a very subjective thing. There is no specific guideline for it or that you need to stick to, but it's good to have a recommended OT size of 20 by 20 into 10 feet height, or at least 250 square feet of area. With you for a minimum requirement of a theater. And of course, it is around the concept that at least 1.2.
Smokers with TED are definitely twice as likely to need strabismus surgery compared to non-smokers who have thyroid eye disease. And of course, family history and genetics also probably plays a role here. So this is a typical patient with thyroid eye disease whom I present to you. As you can see, this patient has a clearly large esotropia as well as a hypotropia in the right eye and a very, very prominent proptosis. So when they come to, I think my slide is some font has esotropia as well as hypotropia, which are the most common forms. And this is because the muscles which are involved often show a predilection, which is a pattern which is very, very commonly described. Like inferior rectus probably is the most common, followed by medial rectus, and then in that order, as mentioned here. And obliques, though not unheard of, but they are very, very rarely involved. Again, inferior rectus, why? Probably because it's a very, very bulky muscle and it is tonically very active because of the position it is in. And that's why probably it gets involved more often than any other muscle. You can have multiple muscle involvements, you can have bilateral, you can have asymmetric, asynchronous involvement. And of course, since the hallmark of myopathy is restriction, you will have a positive post-duction test in these patients. Investigations also look at your endocrinal status, because thyroid, though thyroid dysfunction has no direct relationship with thyroid eye disease, or rather strabismus in thyroid eye disease. You can have a really bad strabismus even in euthyroid state. But it is important for the patient's general well-being that you investigate for his thyroid level. For any diplopia, you would do a diplopia and Hess chart. Post-duction and test is probably the most important clinical test which you will do in these patients, even more than diplopia. Imaging is important, and probably MRI scan is more helpful, which shows disease activity. It also shows the typical tendon spared. You can get confused with any of these entities here. Coming to the management, the non-surgical management probably is required in patients who have either an active disease where there is an inflammatory pathology going on still, angles are not stable. You would probably still look at medical therapy. to look at to not only control the other parts like proptosis and all, but also to give him symptomatic relief from diplopia. So from the strabismus point of view, this is the time where you may think of the botulinum toxin, because at this time the muscles are not tight and fibrous and they are inflamed, but not really the tight cord-like muscles which you see. So probably you can look at botulinum at this stage when the patient is in the inflammatory or early labile stage of the disease. And of course prisms. And coming to prisms, you can give both Fresnel as well as ground in prisms. They are definitive treatment for small angle deviations. Prisms are an option even in the late fibrotic phase if the angles are small enough for you to deal it with the prisms. But while if you're looking for very large angle strabismus, then probably you can give them temporarily while you wait for strabismus to stabilize. As I said, botulinum toxin has a role in a very, very limited small area where there is only inflammation and not much fibrosis. And and then strabismus surgery should be done only after orbital decompression, because orbital decompression itself can produce a new strabismus, as well as it can modify the old strabismus in a way which you did not anticipate. So timing of surgery is always post decompression. And of course, you can use MRIs, serial MRIs to look at muscle edema, and that is a marker for activity of the disease and instability. And if you really see a very enhanced muscle, you probably would want to not do surgery at that stage.
With the existing wall or the existing environment, you make a special separate different environment all for your theater, which does not interact with the rest of the wall or the rest of the environment. So it can be made in the steel, or it can be made with the help of metal and PPC sandwiches like these panels. This is the OT that we use here at Suraj Hospital. So these are large, almost 10 by 6 feet panels, which are fitted in an interlocking way, and the joints have been covered with silicone. So this gives a seamless surface without any places for microbes or dust to accumulate. And the flooring here, you can see it is a polyvinyl sheet, and this is the coving that is done for easy cleaning of these surfaces.
Tight rectus, which is often the case in these patients, proptosis is likely to increase, and multiple surgeries also need to be counseled even before you plan for surgery. During intraoperative considerations, if you have to look, then forced reductions are your friends in every way. Large muscle recession should also be combined with a conjunctival recession to avoid postoperative restriction because of the conjunctival tethering. Dissection of Tenon's capsule, especially around the inferior rectus, is very, very important.
Attachment which you can attach, or you can use some air purifiers which are specifically meant for the operation theater, which are just in addition to your air conditioner that you have attached to your OT. This does not and
it has been described, and with fairly good success rate if you review this paper, which was published in 2006. So as I said, these patients need much less surgery. Sorry, the photo has been reversed here. I have actually done the left eye surgery. Eyelid retraction, again, attachment of the capsulopalpebral head is to the inferior rectus, and a good careful dissection can reduce this, but it is impossible to avoid it if you are planning for a larger inferior rectus recession. A-pattern exotropia, especially very common after bilateral inferior rectus recessions, and this can be tackled by either reducing the amount of medial rectus recession if it is planned, and delaying medial rectus recession if it is simultaneously planned to do another sitting, and also to nasally transpose the inferior rectus can also help it to offset this. The frequency of reoperation in this as high as 50%, so these patients need surgical follow-up, and you must not leave them just because surgery is done and you are done with them. So to summarize, surgery only functionally and cosmetically disabling, quiescent stage, Conservative therapy trial should be given for every patient before you plan surgery, and cessation of the smoking and hormonal control of thyroid is very, very important to get a good surgical outcome. Standard surgical nomograms do not apply, and probably you have to titrate your own dose. In some, almost always improves the outcome, and counseling regarding realistic goals and unpredictable outcome is absolutely mandatory to avoid litigation as well as an unhappy patient. Thank you for the attention.
Thank you, Dr. Sumita. Nita, you have questions?
Yes. Hi, Sumita.
Hi.
I have two questions.
Sorry to interrupt. Meanwhile, may I request Dr. Abha to be ready with her presentation? Abha? Dr. Abha? Go ahead.
Yeah.
Sumita, when we talk about using Botox for these muscles, since the muscles are different, would our dose change? Would it be the same, or would we, if I say you use 5 units for a medial rectus in a lateral rectus palsy, would it be about the same or would it be more? Second question is, in your personal experience, since there isn't too much thyroid, like you rightly said, in your personal experience, would you use non-absorbable sutures more and more, or do you tend to use absorbable and put them on a
No, I honestly have, in 1 or 2 re-ops I have used, but primary I have still been using Vicryl. Regarding Botox, I personally have no experience on Botox in these patients, but I have always felt that it is technically very difficult to deliver the dose in muscle. Conjunctiva is friable, and to hold the muscle, even if you are not really hooking and really going through the conjunctiva only. So when we see angles of 55, 60, we all tend to do 6 millimeter medial inferior rectus recession, and then plan it with another medial rectus recession because they will base a lot of, but probably I burned my fingers and I don't do anything more than 5, even if it is very large angle.
Do you nasalize them, the inferior rectus? Even
yes, if it is bilateral, then yes, not on sync.
Dr. Sunena, you want to say something?
Do we have time?
Yeah, we have time.
Sumita, I just had a question. If you have exophthalmos and a squint and a strabismus, what would you do? Would you wait?
No. Yes, if it depends on what the patient. If a lot of these diseases are like multidisciplinary approach, and you have to work in tandem with an orbital surgeon. So if they are planning to do something for the proptosis, I'm going to wait for strabismus surgery and try all the other things which I said. You can try prisms, you can try occlusion if the prisms are, sometimes the angles are very large and patients just don't fuse. So,
good evening, everybody. I'm really thankful to Dr. Samant Square for giving me the opportunity to speak on the subject. My topic is monoocular elevation deficit. I will be discussing this topic under these headings, that is definition, clinical features, etiology, management, that is investigation and treatment, complications, and the cases. As we know that it is a unilateral deficit of elevation which is associated with variable amount of ptosis. We know that the oculomotor nerve has 2 divisions, that is superior.
Can say that आपने हमारी life change कर दी है. The other thing, the 6th thing is being mindful, that is living in the moment. So often I've been at the clinic and I think I'm not spending enough time with my child, and it's natural. Or there've been times during the lockdown wherein the house is an entire mess and I've hated being at home and I wish I could go to the clinic. And there's this excellent book known as The Miracle of Mindfulness, plus of course enough resources online, which states that you have
be of supranuclear defects or it may be infranuclear defects. In acquired, usually the patient has other systemic elements as well. In the primary superior rectus paresis, you will find that the FDT is negative. The Bell's phenomena will be absent, and seconds above the midline, they are defective. 50% of patients with monoocular elevation deficit with hypertropia in primary gaze have superior rectus paresis. The primary inferior rectus restriction is also a cause for elevation deficit, and in this, depending on the amount of deviation. You can also do posterior fixation suture to augment the transposition of horizontal recti. Following the spiral of telex, it gives a good results. You can do superior rectus resection in less than 25 PD hypo and upgaze ability above midline. The treatment, yeah, as I have told you that we will decide the treatment depending on the result of the FDT. If the FDT is positive, you cannot only undergo NAPS procedure because your tight inferior rectus will prevent the elevation.
These retinal images are then processed in the occipital cortex, and that processing is an amazing thing that occurs, and it's the ultimate processed image. That visual perception is what our patients see. And that is what I think we need to keep in mind, that whole framework, when we start thinking of lenses for each patient. So what are the different options?
And the conjunctival suture. Then we will see some of the cases. This patient had ptosis. You can see the large amount of ptosis. There is an hypo in the primary gaze, which is there in abduction as well as primary position and adduction as well. This is after the surgery, after doing the inferior rectus recession and the Bell's and the NAPS procedure. You can see that it is almost in the normal position. And this is after surgery. Right eye, we did inferior rectus recession with NAPS transposition of the horizontal recti to the vertical muscles. And in the left eye, we did Y split, and the elevation has definitely improved. It was because this elevation has also improved, so there was not much of the upshoot seen post-op. This pre-op.
Every time, and we ended up doing the right eye with a Technis eye-hands lens to try and boost his distance vision even further than 6.6. And this is 4 weeks after the second surgery, 6.5, 6.6, right or left eye. This is the eye-hands eye, and near-photopic 6.12 with the synergy eye 6.6, and near mesopic. And binocularly, he's just amazed. Everything is, he was spectacle free to begin with. He's very pleased. He notices significant.
You have to summarize.
You can see the elevation has definitely improved. There can be complications like undercorrections, overcorrections. There may be changes in the lower lid. In tight inferior rectus, it's very risky. So you be careful.
Abha, stop your slides, please. Abha, you have to summarize. You've overshot your time.
Hello, madam.
Am I audible?
Yes, you're audible.
Abha, stop your screen share. Abha, stop your screen share. Yeah. Go ahead, Shailaja.
Hello.
Yeah, thank you, Dr. Himalini and Professor Malik and Maharashtra Ophthalmic Society for giving me this opportunity. If I'm not clear, just let me know. My voice is not quite in the best of shape. So I am here to discuss about DVD. I call it a mystery phenomenon because till now it's not very quite
reached a place where we can satisfy all the patients or the lenses, because you know nobody can beat nature or compete with nature, and we have yet to reach perfection. Thank you so much, sir. Thank you for giving your time. I now invite Dr. Ramamurthy, sir, for his presentation. He will be talking to us on dealing with an unhappy premium patient. Dr. Ramamurthy, sir, is very well known. He has been the scientific chairman of the All India Society.
Currently fixing eye. The eye which was in the manifest DVD will come down, but there will be no hypertropic movement of the covered eye. In fact, when you move the DVD, in fact, under the cover, this eye can go up again in DVD because DVD is usually bilateral. And when you shift the cover to the other eye, then this will come down. And again, there'll be no movement of the covered eye, or again, it can go up. So both eyes under the cover will go up. So this is a disconjugate movement between the two eyes. Often along with the vertical movement, there is also a torsional movement and also a movement from outside the filter. There'll be a time when the hyper eye will become overshoot and become hypo. And the red glass test, where normally in hypertropia, one eye image, when you keep the red filter in front of one eye, the image would be up and the other eye would be down because of the relative hyper and hypo position. In DVD, whichever eye you place the red glass, the image will always be up or down because the eye is always up under the cover. You measure it using the prism undercover test if you want to have accurate measurements. Now here it is essentially like a cover test, but you have to ignore the movement of the other eye. You have to just look at the movement. 1, 5 to 10 is grade 2, 10 to 15 or more than 15 is grade 3 and grade 4. And even the control of the DVD can be graded like good, fair, or a manifest DVD. Now, coming to the management of DVD, first and foremost, try to give the patient the maximum best possible vision, because good vision is in itself a good stimulus to control the DVD and make it less manifest. So treat the cause of the poor vision, give refractive correction, treat amblyopia if it is there, but it will not improve with time, but it may just come under the control. The surgical indications, first and foremost, is manifest DVD. Now you have to remember that whatever surgery you do, you may not be able to abolish the DVD completely. So the aim is to improve the cosmetic appearance and make a manifest DVD into a latent DVD. DVD can occasionally lead to head tilts or turns, so that can be treated and could be an indication for surgery. And very large DVDs can actually give ocular discomfort when they get manifested. And in small children, it is a independent risk for developing amblyopia. So approach to surgical management, it depends upon the grade of DVD, how much is the DVD, and also the incompetence of DVD. Incompetence means how much it is differing from weakening procedure to address the A pattern associated with it. But remember that the DVD will increase if you do a superior oblique weakening procedure. So you have to combine it with a superior rectus recession, again, large superior rectus recessions. So just a couple of cases. So this is a Commenton DVD. Similar in side gazes and almost symmetric DVD in both the eyes. So this patient underwent a bilateral LR recession for the XT and bilateral SR recession 8 millimeters for the DVD, and obtained a good result. We have published our results of bilateral symmetric and asymmetric superior rectus recessions for DVD of 27 patients. This is in Asia Pacific Journal, and we did 5 to 10 millimeter SR recession. The concern with SR recession is, large SR recession, is that they may develop lid retraction, upper lid retraction, lid fissure changes, and also a V pattern in upcase, which can be avoided. But in our series till 10 millimeters, we did not have these complications, and success was seen in 63%, which was no manifest DVD. So when in cases with DVD, where the DVD is more in adduction, like this with infraoblique overaction, bilateral MR recessions with IOVT were done, and quite good results were there. And this is a patient where PTSO was done along with the superior rectus recession. And so case series have been published from our center as well. So some of the surgical pearls which I want to highlight is that whenever you do a unilateral DVD, a unilateral surgery, you have to be sure that the other eye will not take up, that the DVD eye where you're doing the operation will not take up fixation. Unilateral
severe dysphoto, negative dysphotopsia. This is a gap between the two lenses, and the secondary lens has essentially a concave posterior surface. And this is, as I was mentioning, this is just a piggyback trifocus. Nowadays, we come across patients who have had a monofocal in the first eye, want to have a secondary, want to have a multifocal in the second eye. And just in case you have done that, most often the patients are quite happy with the outcome. And if you want to introduce multifocality in the second eye, we have Indian, both foreign as well as Indian piggyback lenses which are available. And this is one such try.
I'm not going to take any questions except one that, like you said, I think a very important take-home pearl was that if you get, beware of asymmetric DVDs. Because very often when you counsel the patient for one surgery, the other eye starts going up. Nipa, you want to make one last comment on what on Shailaja's presentation before we wind up?
Shailaja, very well said. any in a 2-sentence nutshell, do you have any sense of what sensory changes happen after you correct your DVD? I mean, one indication you said clearly was cosmetic, but do you have
Host.
Start video of Dr. Deshpande, sir.
Yes, host has to start. Who is host?
You are the host.
Are you able to hear me? Prakash?
Yes, sir. Yes, sir. Yes, sir.
Are you able to hear me?
Hello, Mr. Akhilesh Kulkarni, are you here? Akhilesh, yeah. Viral, yeah, we can start.
Deshpande sir is the host now. Deshpande sir is the co-host. We can start now, sir.
No, but my video is not starting.
Then it's from your side only.
Host, Malik madam.
Madam, sir, left-hand side is organized by Maharashtra Ophthalmological Society in this COVID era. And I think it is a virtual conference. All of us are not able to meet physically, but on this virtual platform, we are able to meet. And this is the need of the hour. That is a medical symposium. It has been very well designed by our chairman, Dr. A.A. Deshpande, sir. And I request Dr. Deshpande, sir, start with this topic. And that topic is very much apt. Recently, CPA, that is Consumer Protection Act, it was amended. A little bit different changes were done. All of them were not in favor of medical fraternity. So, biting teeth, COVID Act 2019. Dr. A.A. Deshpande, sir, please.
Welcome to all. Really speaking, this act was there previously also, but because previous act was totally peeled off, means cancelled, and a new act has started. It has a little big biting teeth, and about that only I am going to speak about in detail.
Can you share your presentation? Can you share your, yeah, it is Neha Deshpande screen. May I request Dr. Neha to stop screen sharing, please?
Yes, sir.
Neha band kar.
And you can start sir's presentation.
Share. Yes, able to see?
Yes, sir. Yes, sir.
You adapt less, but give them adequate time, and most often the initial problems that the patients have tend to disappear. To carry on from where Dr. Milind Pandey left off, I will be just sharing a few scenarios, and you can see here, these are just screenshots of my actual patients. A Symphony multifocal intraocular lens implantation done. Excellent distance visual acuity, uncorrected. But as far as near vision is concerned, the patient required a +1 diopter. So essentially, the patient was quite unhappy with the outcome. So what we did in this case was the fellow eye received a +4 diopter thickness multifocal intraocular lens. I believe the second eye operation is an excellent tool that's available to us for titrating the kind of titrating the outcome for these bilateral implantation eyes. As another scenario where again a LRCS with Symphony intraocular lens was implanted, you can see again a slightly deficient near vision where the patient required a 0.5 vision, though the distance uncorrected visual acuity was extremely good. So what we did in this scenario was to did a bit of a mini monovision where we titrated in case the patient had a 21.2 diopter biometry.
It was 20 lakh was the limit of demand, but here the limit is not of the demand, but limit is of bills that you have paid. And up to the paid bills means any hospital has paid, if up to 1 crore, the patient is able to put the case in district forum only. And from 1 to 10 crore, it is at the state level. And from the 10 crore above, it is at the national level. From this act, it clearly indicates that no hospital can do a bill of 1 crore. So this act is now formed, taking in as per limit of the demand. Previously, where the incidence cause of action was started, that was the place where the case can be lodged. But at present, at the cause of action or at the place of residence or workplace of the consumer patient, or it can be online. So a person who has taken from the Karnataka or a Kerala who has taken the treatment in Delhi can lodge a case in the Karnataka or the Tamil Nadu, wherever he is working or wherever he is sitting. So the doctor has to run to that state, go to that court and apply and represent himself. So it is become very difficult for doctors to appear in the courts. Appeals, previously 25,000 was the limit that much used to be deposited in the court for to do the appeal. But now the limit of and it was 30 days limit, but now it has 50% of the order amount. So whatever is ordered by the lower court, that 50% should be deposited in the court before you go for the appeal, and the time period is increased from 30 days to 45 days. The judges and staff was appointed by the judiciary. So there was a genuineness of the cases and pleading and everything. But now their provision is that according to clause 29, the judges and staff will be appointed by the central government. There is a very likelihood that so any person can come and sit in the things. What I have to do? Nothing, just sign and go. And the advocate will put that case and will ask for the compensation of 1 crore. And when the case is referred for the mediation, the advocate will compromise it 5-6 lakhs also. And because doctor will think that instead of running the case, giving the advocate and all that and appeals everything, why not to settle for 4-5 lakhs and get away of the case? So he may accept, and if he accepts, the money, easy money, goes to the patient and advocates. So this is a real way of easy money, official legal easy money to advocates and patients, for which the doctor has to suffer, and so it may happen. This mediation clause is dangerous from that point. The services are not defective, is not so easy. So this is a very big biting teeth to the doctors. Another thing is that Central Consumer Protection Authority, to be known as the Central Authority, clause number 15, investigating authority. So this was also not there previously, but now this authority has started. A separate authority is made at the center, and at the state level and district level also their branches can be there, and they are having so much of powers to go in any hospital and can do the inquiry of their advertisements, what they are.
This was not included in that particular revision. People thought that medical fraternity, medical community, doctors are out of this Consumer Protection Act. And there were so many rumors that this particular act is not applicable to medical fraternity, but it is not so. Because of that exclusion list, medical fraternity, medical service is not written in that, we are not excluded. So please remember that medical fraternity doctors are still under Consumer Protection Act. And I think with all these remarks, I request our new presenter, Dr. Neha Deshpande madam, who is a medical legal expert. She will be speaking about problems faced in medical practice during COVID. Welcome, Dr. Neha Deshpande.
Thank you, sir. Am I audible?
Yes, yes, you are audible.
The second most challenge met by the health workers and all the hospital staff was switching into the scrubs at the entry to the hospital and again back to the street clothes at the exit. So bath was mandatory once you reach home, which made it difficult for conducting the OPD in the morning as well as the evening. There was a lot of discomfort in breathing by N95 mask, face shields, sweating, lot of dryness and burning to the skin caused by the alcohol-based sanitizers. The challenges faced at the reception were patients were to be greeted only with namaste, there was no handshake. Loss of human touch was also observed because the staff couldn't help the elderly, the patients who were in pain, or the patients who are blind. Separate staff was needed for thermal screening, for taking history, and monitoring the pulse and the oxygen saturation of the patient. Payments were to be avoided in cash, but the patients from rural areas preferred cash transactions, and so all the safety measures were to be taken. There was an additional burden on the registration desk to educate the patients about COVID, also to explain the patients and their relatives about the COVID consent form and get it duly signed. Patient had to be counseled on the phone prior to the appointments regarding the safety precautions which were taken in the hospital. Many patients were apprehensive about getting the COVID test. So they used to inquire whether the COVID test is. There was a periodic display of COVID updates to be maintained in the hospital. Additional requirement of the staff for cleaning of ophthalmic instruments was needed. And if you volunteered yourself for the safety precautions, there was a lot of loss of time for the sterilization between every patient. Fogging of lenses was challenging while doing refraction. Because of the avoidance of the tests like NCT, the syringing, or direct ophthalmoscopy, there was chances of missing the findings. Also, the waiting time had to be minimized. There was less communication between the doctor and the patient as less speech was to be observed, which led to incomplete assessment of the patient. Patient who were COVID risk or who were positive bearing ophthalmic emergency were to be referred to the multi-speciality hospital with ICU facilities according to the ICMR guidelines. Privacy concerns were at stake due to the open door policy. The challenges met at the operation theater were all the surgeries were to be a daycare surgery. Additional investigation of routine chest X-ray was advisable, for which the patient had to go to a radiologist to get it done. Surgeries off hours with incomplete staff were to be avoided. To lessen the surgical time to minimum, the disinfection after each surgical procedure and a gap of 20 minutes was to be observed. In addition to this, the hazards of sodium hypochlorite, such as burning pain, redness, swelling, and blisters to the skin was observed. It caused coughing and irritated throat because of the aerosol inhalation, irritation to the eyes. The metal surfaces had a corrosive action because of which the chairs and the furniture in the hospital got spoiled. In addition to that, sodium hypochlorite has a mutagenic action. The gas caused a lot of respiratory discomfort. There was less water and food intake because of the PPEs. Fogging of lenses was observed by the spectacle wearers. In addition to that, because of the chemoprophylaxis, there were side effects, and it gave a sense of false security with the gears and the chemoprophylaxis. Last but not the least, low income to expenditure ratio. Patients were less, but more staff had to be maintained. All the staff members, as well as the doctors, had to spend on protective gears. Even the patients who were not carrying their disposable masks, gloves, were to be given from the hospital. Barrier installation of the barriers to all the instruments, slit lamps, all the desks had to be done. The disinfectants were to be used generously. The housekeeping expenses also gone high up as 2 hour cleaning of the floor was to be observed. Thank you.
Explained very nicely the things that really the doctors were experiencing. Now I will call Dr. Anil Kulkarni, and everybody knows Dr. Anil Kulkarni. There is no need to give any introduction to him. Whole of the Maharashtra knows him well. The post-COVID economical recovery of ophthalmic practice, because the COVID locks, lockdowns, and so many curfews and so many things. So whole economy of the doctor hospitals has changed and affected, because lot of overburdens were there. The overheads were there, staff was there, and staff was to be paid, and everything was to be maintained. And in the COVID period, extra precautions and all that, kits and every expenses were so high that the economical balance was totally lost of hospitals and doctors. And Dr. Anil Kulkarni will throw light on that and how it is to be post-COVID, how they should be managed, or how it can be done. Will tell you in detail. Thank you. Dr. Anil Kulkarni.
Yes, sir. Desktop now block line.
Yes, please.
Yeah, just a minute.
Oh, yes, yes. Okay.
Okay, can you see my slides?
Yes, yes, able to see.
Okay. He put this photograph with me, and I thought this is Kung Fu Panda. Last 6 years till I saw the movie. Thank you very much, my friends. And I think I don't know whether I exceeded my time, but this is all. And when I get into this leadership development program, and I shook the whole world on August 15 and 16 when I did the International Council of Ophthalmology Leadership Development Program. And I not controlled. I probably taught leadership to the whole world. And thanks to that, and yesterday I told Sunena, one day I'll become president of the International Council of Ophthalmology. Thank you all.
Yeah. Thank you, Dr. Natarajan. Thanks a lot. You are the real brain behind the LDP. And we, three of us are there, alumni of LDP, Dr. Taswala, myself, and Dr. Harshul. So I welcome everyone. I welcome Dr. Sunaina Madam.
You can imagine the additional expenses which were unnecessarily required because of these virus problems. And to compound the matters worse, there was a reduced income, which fell down to 10 to 20% for the initial 3 months. Another problem was unwilling staff for reporting to duties because of the fear, or sometimes because one of the relative gets the problems, they were quarantined. And last but not the least was the government threats, so-called guidelines, which were saying that you have to keep the facility open, otherwise, as well as the staffs, realize that there are safety measures which are being taken in this hospital, so some of the problems will go away. Now you have to change the ambience of the entrance, because not only that you are going to follow the recovery steps, but it should be seen also by the patient that yes, this is the hospital which is really taking safeguard actions against the virus transmission, and the confidence of the patients in us will increase so that they can now say that, okay, I would like to take the treatment. Now, there are a lot of people every day which always say that, no, they don't need mask. And if the President of the United States doesn't need it, then why should they need it? But then this COVID readiness and maintaining social distancing and insisting on the mask became a big factor, but then it has to be implemented for the safety of everybody. Like we have shown this standee over here, this kind of standees were displayed at all places in our hospitals. There were videos which were circulated through social media to show how these ways to fight against COVID are being actually implemented in the hospital. Because that creates an awareness that, okay, now it is safe to take the, at least in ophthalmic treatment or even the elective surgeries. The AMCs or annual maintenance contracts of all our equipments, which runs in lakhs, were fortunately extended by at least 4 months because of the efforts by AOS Managing Committee.
This was a big hit. As you can see, we have amazing talent in ophthalmology. This is one of the painting by Dr. Suhas Sarvade. So he's a great painter, an artist, and as well as photographer. So what we do in this group is we always give post of the day. We always kept some incentive or some something for all the members to keep them motivated, to keep them pushing to showcase their talent, so that they come up with something new. So it's just, and I'm very thankful to Antod Pharma for this, that right from the day this group was created, Mr. Nikhil and Mr. Kishore Masurkar were very kind that they will give support, whatever support we need for this growth.
So counsel the patients, discuss with it personally, and whatever is the standard surgical or procedure charges, try to adjust it or discount it depending on what suits that individual person. We were earlier also, and majority of us normally have standard charges, display them and tell them that these are the things which we are going to do. What I found out was in these situations, people started window shopping and asking other hospitals how much you charge for this surgery, how much is good. Oh, this is not needed. There is hardly any patient who has the insurance. But now, whenever the ready cash is going to be lacking in the people's pockets, this insurance, those who have insurance, will always come in handy. For ophthalmic surgeries, you are aware that unless the policy is in force for more than 1 year, usually they will not give any reimbursement for the ophthalmic elective surgeries. So it is always better we tell the patients also to get yourself insured so that whenever you require a problems, this kind of economical problems will be less because you are insured. As of today, realize that survival for us is important and survival for the patient's economical survival is also important. Once you do that, profit and recovery will surely follow. So there is no reason for us to get depressed. We will recover. We will go with a much better boom in the economy, provided we survive at this stage, whatever is happening and whatever we are trying to achieve. Thank you for your patient hearing, and my special thanks to Advocate Dr. A. Deshpande for taking out this important topic. And this Consumer Act, what he has shown us in his lecture, probably is quite threatening, and I think we should learn it. I remember only one thing when I say that ignorance of the law is never taken as an excuse for any wrongdoing.
As I would have liked it to be. And we proceeded with the surgery here. We are injecting some phenokin in the hope that this pupil will not constrict. At this point, I was trying to decide whether to use a ring or something, but I felt that I would be able to complete it without any problems. So, however, as we proceeded with the surgery, and you can see that it's a really hard cataract, we encountered problems here because the pupil was becoming smaller. And at one point, it became difficult to go ahead and complete the surgery. So I used again another supplementation, and you'll probably see that now pupil size does become much better, and it allows me to complete the surgery at this point without much difficulty over there. And here we were able to. So I think at 2 points we use supplementation, and you can see that the effect does come. I was asked by somebody that, once you've had phenokin, after that it doesn't work. But as you can see here that we've used it thrice, once at the start of surgery, once in between, and once a third time just before the nucleus was completely removed. And we do have an adequate pupil size.
National IMA headquarters, New Delhi, Standing Committee, Prevention of the Diabetic Retinopathy Blindness, CWC member, National IMA headquarters, New Delhi, Managing Committee member, All India Ophthalmological Society, past President, Maharashtra State Ophthalmological Society, past President and Advisor, Pune Ophthalmological Society, and the member and of the Standing Committee of the Legal Cell. He is with me in this legal cell. So with all these stars on his coat, I request Dr. Prakash Barathe to talk about.
Can you see the slide now?
Yes.
So I am thankful to Maharashtra Ophthalmological Society for giving me this opportunity, and thankful to our chairman, Dr. A. Deshpande sir, our stalwart past president, Dr. Anil Kulkarni sir, Dr. Neha Deshpande, and my colleague, Dr. Viral Shah, and the audience. I think this is the era of COVID, and in this COVID era, most of us have just started one thing. And when discussions were going on, it was the saying, you should keep one thing in mind, just survive in 2020. See, this is very important. Survive. Sir, mute kara sir. Deshpande sir, tumse mute kara. So what I said, that you should survive yourself in 2020, and not only yourself, but your practice. I think that is the basic need which was there in 2020. With these minimum expectations in your mind, probably you should be satisfied, you should be happy. So about changing trends in practice in COVID era, my previous speakers, they have talked about on this issue that when COVID has hit, what changes they have made in their ophthalmic practice. And these changing trends are very important to survive in this COVID era. What were they? I think online medical checkup and consultations have already started. Now see, because of COVID, patients were not coming to hospitals. They were not ready to meet you. Even doctors were not ready to meet the patients. And online medical checkup and consultations, that concept which was not there in the past, has started in this COVID era. So what I say, take this as opportunity to project
for it. All of you have been witness to that. After 4 thoroughly, and I'm not saying bitterly, because I was never bitter. After every election that I fought, I was never bitter. I'm not that way. I'm very positive. But after 4 thoroughly fought elections in the MOS, then to be elected unopposed and to have such a fantastic year, that was the cherry on the cake. Means it was absolutely great. This year has been fabulous in my own opinion. I don't very much care what others say. I always think about what I feel. It's never easy, you know. Reaching for the moon is not easy. Otherwise, every second person would be doing it. And don't believe people who tell you it is. Because there'll be lots of people telling you, kuch nahi hota."
hospital, that was the issue. And in that case, protective gears to be used for direct physical consultations, and that was must. And of course, that was increasing your cost. In this COVID era, government rules and regulations were quite tough. Doctors were thinking that if they don't see patients, probably they will be safe. Few of the OPDs and hospitals were not working, but still, many of the doctors, they were putting themselves in danger zone. Few of the doctors, they have lost their lives also. And one important thing is there was insurance for doctors.
Thanks to all those who helped me in my journey of reaching for the moon. Thanks also to those who tried to obstruct me in this endeavor, because they spurred me on. You know, they also serve a purpose, believe me. And as Amitabh Bachchan says in Kaun Banega Crorepati, Kab tak rokoge mujhe? Thank you so much all for this patient listening.
They can see these pictures online and can interpret, and that way they can advise you, suggest you various options of treatment. So involve various super specialists for
treatments, and they don't really solve the problem. And they have all kinds of ingredients. When you look at bottles of artificial tears, you see all the stuff in them. It just drives you crazy because you have no idea what it means. So when I first read about demulcents, which are things that supposedly relieve irritation, and they're kind of like, you know, wood pulp, cellulose, and liquid polyols and various chemicals, they're just sort of gluey stuff to put on your eye to make it feel better. And then we have emollients, another name taken from dermatology, which is something that is generally used in cosmetics to soften the skin in ladies who want soft skin. But what it does is it adds lipids, and so that helps us improve the lipid layer of our tears. They're in all the tears. But then we have a whole bunch of other stuff. We have physical things, like we start to see rheological additives in the last 5 or 10 years, which are basically hyaluronans or other devices that don't work as well as hyaluronans, viscosity enhancers, thickeners, gelling agents, all kinds of stuff. And
so active in all his associations in the Nagpur as well as Vidarbha area. So we welcome Dr. Viral Shah, and I request him to start his presentation. Dr. Shah, please.
Thank you. Thank you, Dr. Anil Kulkarni, sir. Thanks to the scientific committee of Maharashtra Ophthalmic Society to give me this opportunity, and special thanks to Dr. A. Deshpande, sir, Dr. Prakash Marathi, sir, and Dr. Neha Deshpande, my co-faculties for this webinar. My screen is visible to all by MSME Minister, MSME Ministry, and the MSME Minister right now is our Honorable Shri Nitin Gadkari ji itself, and he has brought about many dynamic changes in this act and made it very user friendly. So I will just touch upon some of the salient features. Yes, the board is created and all that. This you can go through. I will just touch some highlights. So whether it is applicable to us or not, the MSME is divided broadly into two categories: manufacturing category and service enterprises. So manufacturing category, also some doctors are using it for some their optical manufacturing. It is for a limited purpose, but service enterprise, yes. Service enterprise, yes. Each and every healthcare sector comes under service enterprise, and all doctors are welcome to get registered into MSME. So can doctors take registration under MSME as per MSME Act 2006? Yes, MSME covers manufacturing as well as service sector, and hence doctors can take the benefit of MSME registration. Why to take and what are the benefits? That's what I am going to highlight in very short. So previously it was micro, small and medium. The definition changed with effect from 1st July of 2020. Now if your investment is less than 1 crore, you are micro. Your initial investment is less than 10 crore, you are small. And if it is less than 50 crore, it is medium enterprise. So what is the use? I will come later. Udyam registration was also bank account. If it is there, it's okay. If it's not there, you can even get Udyam, that is Udyog Aadhaar card memorandum, right? So
What is problem? You are not being heard. Are you able to hear him? Hello?
No, sir. No, we cannot. We can't hear him.
You are able to hear me?
Yes, sir. Yes, sir.
Dr. Viral.
Yeah. Now you are audible, sir. Unmute yourself. Unmute
Now
yourself.
it is okay.
Yeah.
Okay.
Yeah.
Continue.
Right, sir? Now I'm audible, sir?
Audible.
Yes, sir.
Yes.
Now I'm audible, sir?
Yes. Now you are audible. You can continue.
Hello?
Yes.
Dr. Viral, you are completely audible. You can continue your talk now.
If you are a new practitioner looking to, you can get from the bank. Yeah. So if you are a new doctor or a new practitioner, you are going to start. Sir? Hello?
Yes, you are audible. Completely audible. Continue.
I'm audible now?
You can off your video.
Yeah.
You can off your video and you can start the presentation.
Okay,
Continue
sir.
the presentation. Put your video off.
Okay, sir. Yeah, I will do it, sir. Yeah. So if you are a new practitioner,
no slope at all, and they're basically Newtonian. So you'd expect that these kinds of tiers should give the patient a better result and last for longer, like the Hyla shield that we first made did in the 90s. So it's hard to ask 1,000 patients because, as you know, patients all give you different answers. But what you can do is you can go to a lab and you can measure them. And you have this stuff called normal stress. And normal stress is because when you have a polymer and you exert shear force on the polymer, the globules of the polymer, which are sitting at rest, will elongate. And when
from time to time, and also if you want to start manufacturing, doctors are now procuring their own medicines and marketing. They have got a pharmaceutical license. They are marketing out themselves, and they are directly selling it to the various outlets, and they are reaping the benefits. So there are many benefits. You can go into details. Always consult with your chartered accountant or your accountant or your lawyer. But benefits are going to increase day by day because government is giving more, and
we make better artificial tears. And it looks like from rheology that we probably can. And so hyaluronic acid-based tears seem to show that
taking advantage of this MSME scheme.
Thank you, Dr. Viral Shah. Actually, this is a very new concept and a very nice one by which you have put it. Sorry for the troubled and unstable connection. So some of the things were lost. But I think you have given a food and thought for the people to think about it. With the present scenario, if you can get some amount of additional help through any schemes, including the banks, obviously it is welcome. So I think our members will also feel it much nicer.
These loans are, yes, sir. These loans are
same. So I think herewith I would like to invite our last speaker, Dr. Harshul Tak, a very close friend, and today he's celebrating his birthday. So wish you a very happy birthday, Harshul, on behalf of all of us.
Thank
Over
you.
to you.
Happy birthday, Harshul.
Thank you
Happy
so
birthday,
much,
Harshul.
Dr.
Happy
Vardhman,
birthday.
Dr. Ragini ma'am, and everybody there. It's a great to listen to Dr. Arshinov again. And so I'll be speaking on some challenging case scenarios. So I'm so sorry that something was grossly wrong with my laptop, so I have to pull it out from like this. Okay. So the first case which I'm going to share is the scenario is the intumescent cataract. Am I audible there?
Yes, yes.
Okay, can you see my screen?
Yes.
Dr. Vardhan? Yes, okay. So we all know that it's really challenging to complete the capsulorhexis in intumescent cataracts because there is increased intracapsular pressure, and all this liquefied cortical matter which is there, it increases the intracapsular pressure, and there are higher chances of leading to Argentinian flag sign in these kind of cataract, intumescent cataract. So the technique which I've been using is the sequential two-stage capsulorhexis. So stain the capsule with trypan blue. You can see these spokes here. These are all liquefied cortical matter, which is increasing the pressure. So I go ahead and make a very small opening in the center using a microcapsulorhexis forceps. So as I showed you the dome, it's easier to walk at the center of the dome in this central area. So I'm making a very small capsulorhexis using a microcapsulorhexis forceps. And once you have this opening, now you go ahead with 27 gauge cannula, and you see this whole liquefied cortical matter is coming and decreasing the intracapsular pressure. So don't try to stretch the capsulorhexis margins, even though it's small, but still these capsules are very fragile. So I go from the another side port to debulk from this area, and even I go make a second side port to go from this area. So once you have debulked the capsular bag, then is the time to go and make a tangential cut using the micro scissors. So you should have these instruments in your armamentarium. So go ahead and make a tangential cut, and now you see I can easily make a capsulorhexis of 5.5 millimeter size in the what we actually desire, because there is no raised intracapsular pressure. And so I've been using this technique for last 10-12 years, so it works very well in these intumescent cataracts. So once you have made the capsulorhexis, most of these intumescent cataract, they are very brittle, so there's nothing great in chopping them, but be careful that there is no cushion of the cortical matter behind, so you should be careful of the posterior capsule. So that's how you complete these cases. So then we can have a Morgangian cataract like these. And the problem in Morgangian cataract is that the capsule and zonules, they are very fragile, and there's no problem of the raised intracapsular pressure, because as soon as you give the nick, the entire liquefied matter comes out. But see, they are the plaques in the anterior capsule, and zonules are weak. So you have to be very careful when you are completing your capsulorhexis. And another problem with these Morgan cataract is the chopping, which becomes difficult because there is no support of any cortical matter there, which is not there to support, so it's freely mobile in the capsular bag. So you need to be a little bit tricky in chopping these cataracts. See, there is no support there, so you go with the bevel down, bury it in the substance of the nucleus, and here you can use this horizontal chopping technique. Get the chopper from the equator so that you can divide it nicely. So get a good purchase, good hold, and then you can divide the nucleus, and in this way you can finish these Morganian cataract. So let me take you to another situation. Sorry, that is, of course, post-polar cataract, which is the not a good situation for any cataract surgeon. These are the true posterior cataract which have onion ring appearance, and there are high chances, we know that once we take out the central plaque, the posterior capsule opens up. So you should plan it from the beginning that your capsular axis size is not more than 5.25 millimeters, because if you require to put a 3-piece IOL in the sulcus and do the optic capture, your capsular axis should not be more than 5.5, 5.25 or 5.5. So you make a adequate size capsular axis and just do some hydro delineation. No hydrodissection should be done in posterior polar cataracts, we all know, in true posterior polar cataract. So once you do that, then you go ahead and start chopping the nucleus, and always try to not to put more torsional forces in the nucleus, and bury your tip in the center and chop it. So once you chop it, you just divide it and separate it slightly, turn the bevel on one side and again chop, and take this piece of the cake out, and in that way you just take out this nucleus. And once you are done with the nucleus, you are left with the epinucleus. So you should go in this manner, that you take out the nucleus first, loosen up the epinucleus from all around, and once you have done that, then you try to flip it. Take this epinucleus sheet. So this is the epinucleus sheet which is coming. This is the last portion which is coming. So this is the epinucleus sheet. Now you are left with this cortical matter there and the central plaque which is there. So because once the central plaque is lifted, as you see, I can see that there is a PCR here. So you should never panic in this situation. Always try to maintain the anterior chamber, because if you just you take off all your instruments at this stage, the rupture which is there, posterior capsule rupture, it will enlarge, and the anterior vitreous phase, which might not be disturbed, it will get disturbed, or more vitreous will come out. So always try to maintain the anterior chamber. So before taking out my phaco probe, I go ahead and put viscoelastic, whatever viscoelastic you have. If you have viscoat, that's good. Even if you don't have viscoat, go ahead and put viscoelastic, and then take out your phaco probe. So principle is to always maintain the anterior chamber, and then you go ahead, stain the vitreous with triamcinolone, do bimanual anterior vitrectomy. You can do from the limbal route, or if you like, you can go through pars plana. So once you are done with the adequate vitrectomy, and then you can easily take off the cortical matter which is there in the capsular bag. So here I have just finished the anterior vitrectomy, and then I go ahead and strip the cortical matter. So once you have done complete anti-vitrectomy, then only you will be able to take off this cortical matter nicely. As you can see here, there is no traction because there is no vitreous in anterior chamber now, so I can easily take off the cortical matter. And this is the last piece of the cortical matter. So I change my hands, again maintaining the anterior chamber, put viscoelastic, then come out, and this is the, so you can see a big posterior capsule rupture here, which is typical of posterior polar cataract. So once you clear the capsular bag of the cortical matter, then is the time to put again maintain the anterior chamber with viscoelastic before you come out, and then put a 3-piece IOL in the sulcus. So I go ahead and put a 3-piece IOL. So I put the leading haptic there and put the trailing haptic also, and then I go ahead and do the optic capture, put some viscoelastic and use equivalence hook to capture it from both the sides. And this capturing is very crucial for long-term stability of the IOL in the sulcus. So once you have captured it nicely, just check it that you have captured it properly and put some myocol and constrict the pupil and your job is done. And so that is how you need to manage the case, typical post-polar cataract. And this is the post-operative photograph. You can see it's captured nicely. Optic capture is done and IOL is very stable. So this was one situation. Then Dr. Vardhman, do we have time?
Arshul, we are slightly behind time right now.
Okay. So I think I'll finish here, and thank you very much for giving me this opportunity. Thank you very much.
Thank you so much sparing your birthday with us, and the presentation was very, very nice. Eco, I think.
Yeah.
Yes. Thank you, Arshul.
Thank you.
Yes. So, yes, I think Dr. Ragini ma'am wants to say something. You will have
She's
to
muted. Ragini ma'am is muted.
Unmute yourself.
Yeah, sorry. So thank you, Dr. Harshul. Have a great birthday. Have a great life.
Thank you, ma'am.
On behalf of the Maharashtra Ophthalmic Society, President Dr. Malik Madam, Scientific Chairman Dr. Preetham, Secretary Dr. Vardhman, the whole dais, Dr. Santosh, Dr. Aditya, I really want to thank the FACO superstars. Dr. Arsenov, sir, joined us when it was not even daylight in Canada, around before 5 a.m. Thank you so much, sir. Dr. Ron Yo, Dr. Milind Pandey, Dr. Ramamurthy, Dr. Padmashri Mahipal sir, Dr. Suhas Hadipulkar sir, Dr. Harshul Tak, Dr. Gaurav Luthra, and all the audience who took time out on a Saturday afternoon to enjoy the lovely talks. Thank you so much. Thank you.
Thank
We
you very
end the
much.
session now.
Thank you,
And
ma'am.
thank you everybody for being with us.
Thank you so much, ma'am. It was a wonderful session. And now I would like all of you to stay back for one of its kinds inauguration ceremony of Maharashtra Ophthalmological Society. Can you check the echo, please?
There's an echo coming.
Yeah. This.
You need to, Vardhman, you need to mute
people.
other device which you are logged in.
Other devices.
Hello. Still there.
Vardhman, it's still there. Mute other devices. All other devices.
Oh, my.
Sir, can you check now?
Now it's fine, I think.
Hello.
Yeah.
No, it's still
Little
there.
better.
Yeah, but so basically, yeah. I don't know. Go back. Hello.
It's still there, Vardhman. Still coming.
Hello. Hello. It is still there.
Still there.
I think you should log on.
Vardhman, you have a laptop in front of you, right?
Yes.
Yeah, so why don't you switch off the mic and use a headphone and start talking?
Yes, do that. Or just use the laptop microphone. Don't use the mic. Don't use the mic.
Now you're mute.
Oh, I'm not mute. Am I? No.
I think Vardhman is mute now.
Hello, Namrata.
Hello, ma'am.
Nice to see you.
Yes, ma'am. Vardhman
We
is
are playing one inaugural video just for a teaser, just of 1.5 minutes. So
wait, Mr. Rahul. Just let's get over the Zoom, the echo thing.
Rahul, just wait. First, let's sort out that problem. Only then we can go ahead with our inaugural program. And I would request everyone to please stay back, those who are in Hall A, and ask your friends to join you from other halls, because this is going to be a one-of-its-kind inauguration, and we have the renowned Professor Palikaris, who is joining us and giving an oration, his oration. So please join. You don't want to miss it. And you don't want to miss seeing me also, obviously. Just joking.
Hello.
Vardhaman, lot of echo.
Good afternoon from Greece.
Good afternoon, everyone.
Hello, Professor. Welcome.
Good afternoon, sir.
Good afternoon, sir.
Hi.
Good afternoon.
Such a pleasure to see you.
Very much.
Absolutely.
Hello.
Vardhaman, I think go ahead.
Good afternoon, sir.
Yeah.
Jaisa bhi hai. Go ahead.
Hello. Okay. I think, well, 1 second.
Good afternoon, sir. Good evening, Namrata. Good
Hello.
evening, ma'am.
Hello.
Is Dr. Mahipal
Hi,
also
Ragini. How are you?
Dr. Mahipal, are
Good.
you?
I'm good,
Yeah, I think
Namrata.
sir is
I am here. Yeah, I am here. I am there for the last
Good
session.
evening and welcome to our inaugural function.
Yeah.
Both of
Thank
you are
you.
chief guests. Dr. Palikaris is our guest of honor. We are delighted to have all of you with us.
Our pleasure.
much, ma'am. Thank you so much.
Thank you.
Actually, we are doing it part physical and part online. That's why some glitches are coming up, but we should be starting in another few minutes.
Hello. Am I audible now?
Yes.
Yes. Is there any echo?
No, not now.
Okay. Thank you so much. So welcome, Professor Palikaris. And thank you so much for sparing your time in this COVID times for Maharashtra Ophthalmological Society. And it is the greatest honor for all of us in Maharashtra Ophthalmological Society to welcome you and to host you. I will just, in short, introduce you with our president, Dr. Malik Pam. So Dr. Malik Madam is the president of the Maharashtra Ophthalmological Society. Then Dr. Mahipal sir, he is the president of the All India Ophthalmological Society. Dr. Namrata ma'am is secretary of All India Ophthalmological Society.
Hello.
And of course, we have our scientific committee chairperson, Dr. Preetham here. So yes, and we have all the friends and colleagues who have gathered here to listen to your oration and a very historic talk on the birth of LASIK surgery and innovations of your life, Professor. All right. So I think very shortly, we will start with the inauguration ceremony.
Neha and Vaishali, go ahead. I think Rahul,
Yes, ma'am.
play that video first. Let them play that video first, Neha.
Yes, ma'am.
Thank you, everyone. Over to you, Neha ma'am and Vaishali ma'am.
Yes.
A very great evening to all the accomplished delegates, accomplished guests, and our delegates. I, Dr. Vaishali Une, along with Dr. Neha Deshpande, take immense pleasure in welcoming you all to a one of its kind special WorkOn, a MOSCON, MOSVIRCON. Today is a special Saturday, the 7th of November, and we take immense pride in inviting you to this special WorkOn. We now would like to welcome our distinguished and accomplished guest.
A mediocre teacher tells, a great teacher explains, a superior teacher demonstrates, but great teacher inspires. The teacher of teachers, person who performed the first LASIK surgery on human eye, Professor Palikaris. Welcome, sir. Leader is the one who knows the way, goes the way, and shows the way. Our great leader, of sector of side chain of hospitals and president of All India Ophthalmological Society, Dr. Mahipal Sachdev. Welcome, sir.
It gives me great pleasure in welcoming Dr. Namrata Sharma, Secretary, All India Ophthalmological Society, and a professor at the Premier Institute, AIMS RP Center. Yes, she is role model not only for all the women in ophthalmology, but also in general, all ophthalmologists. Welcome, ma'am.
Thank you. Thank you so much.
We also welcome Dr. Prakash Kankriya.
And Dr. Jeevan Ladi, our ex-MOS presidents. We welcome you, sir. I would just like to say a few couplets in Hindi for our all distinguished guests. दिल को सुकून आता है आपके मुस्कुराने से और महफिल में रौनक छा गई है आपके आने से. Welcome you again. We ophthalmologists are known to shed away the darkness in the patient's life by giving them vision. And here, sir, I would like to tell that in Indian tradition, we always have the inauguration by lighting of the lamp. So here, let's hope that we shed away the darkness of ignorance and light the lamp of knowledge and peace. "2020 has been a great teacher, and we have been great students as well by getting used to the new normal. So this is the new normal of deep prajwalan or the lighting of the lamp.
So I will invite all the distinguished guests, Dr. Palikaris, Dr. Mahipal Sachdev sir, and Namrata Sharma madam to virtually do the digital lamp lighting ceremony.
Thank you so much. I now take special pride in inviting my mentor, my PG teacher, the enthusiastic ma'am, none other than Dr. Sunaina Malik ma'am, who brings cheer along with her wherever she goes. Her enthusiasm always has been a great motivator for us all at women Aurangabad, of course, not even in Aurangabad, but I would say the Maharashtra state and also the national. So, ma'am, I invite you and I congratulate you for the stupendous, successful tenure of yours as president of MOS. I invite you to give the welcome speech and as a president MOS.
Sorry. So sorry, just a minute. I forgot to share screen. Good evening, ladies and gentlemen, and all distinguished guests on the dais. It is my utmost pleasure as organizing chairperson of MOSVIRCON 2020 to welcome all of you at this August occasion. I will not take much time, but I would like to go ahead with my speech as outgoing president. My presidential year last year was dedicated to these two persons. My father, Dr. R.S. Ahuja, who I'm sure is looking down upon me from somewhere and must be blessing me because he was always so proud of me. And my husband, Dr. Anand Malik, who has been waiting for 7th November to come so that I would be rid of this presidentship and he could rest in peace. Otherwise, I was always on the phone with somebody or the other or on a webinar I'm sure Namrata must be understanding my predicament. And somebody told me, this year that yours was a 0 year and you should have a continuation of your year. But I don't think so at all. Not at all. On the contrary, let me tell you, looking back, I have a deep sense of satisfaction, a huge feeling of gratitude, and an overwhelming fear of achievement. I'm saying it myself, but I do have that. We started with the Buldana CME on 1st of December 2019, which was organized by Buldana Society, and they call themselves BOSS, and they really are BOSS in every sense of the word. Dr. Sean Chinchole started my official year as president with the first CME. This was followed by the POS annual conference on 6th to 8th December at Pune. Then came the OSN, that is the Ophthalmic Society Nagpur on 15th December. And then Corona struck. We didn't know till then what was happening. So, but as they say, when the going gets tough, the tough get going. And that's exactly what we did. We turned our challenges into opportunities. We started with our first webinar on refraction in children and myopia control in March 2020. We never looked back after that. We had a series of wonderful 17 webinars covering the entire gamut of ophthalmology at intervals of 15 days, which were well attended. Our average attendance used to be 2,000 and more sometimes. We had marvelous speakers, both international and national, and this has been appreciated by all our members. We had 2 COVID-related webinars, first one for OPD staff of all MOS members, the second one for OT staff. Most importantly, both were in Marathi so that they could understand. But as you know, all work and no play makes Jill a dull girl, and I'm never that. So we had a singing competition, MOSK Singing Superstars, which was wonderful. We had such a good response. And then we had one webinar on mind, body, and soul, which was also fabulous. We had the very eminent Dr. Rutuja Divekar, well-known dietitian, with us. Then we had a membership updation drive. For the first time in MOS, 1,740 members out of the total of 2,300 updated their own data, which is hugely successful in my book. Vardhaman will tell you more about that in his talk. Then there was the huge task of allotment of new membership numbers, which had been not done since years. And this was taken up by my very dynamic secretary, Vardhaman Kankriya. I'm really proud of him. We had online voting in MOS. This was my dream, always to have online voting, which we never had in MOS. So for the first time again in the history of MOS, 71% voted online, which means about 1,240 members voted. There were a few glitches, but a big thanks to the Election Commission who handled it all, and of course to Vardhaman. We are now in the process of issuing tech-savvy membership cards with the members' photo on it, a QR code, and a barcode. This will take away from the necessity of each city having to make ID cards for their registered delegates in future. And of course, the MOSVIRCON 2020, our first virtual MOS conference, which you have experienced today, and I'm sure it must have matched up to your expectations. A big thank you again, will say, to this trio, my very dynamic secretary, Vardhaman, my treasurer, Dr. Santosh Bhede, and Dr. Preetham Samant, Chairman Scientific Committee. I don't know what I would have done without these three. And I think the 4 of us gelled so well together. We were always on the same page. There were no hassles at all. I'm going to miss our conference calls and the talking and the decision making. There's going to be a huge void after this. And now, of course, how can I wind up without saying a huge thank you to my own family who they are there with me. Bend down, guys. Bend down, guys. This is my granddaughter and my lovely family who have borne with me for so long, for this 1 year, who have kept their patience and let me do my own thing. So Thank you all. Wishing you all a very happy Diwali. Before I get emotional, Jai Hind, Jai Maharashtra.
Wonderful, ma'am. You are always going to be a role model for us.
For everyone, I agree. You cannot run office without secretary. Now I welcome Dr. Vardhaman Kankriya to give the secretary's report.
Thank you. I think you will have to stop sharing. Thank you so much. Yes. Thank you so much. First of all, I think I'll start with gratitude towards Dr. Malik ma'am being our leader. Still echo? Hello? Yeah. Am I audible now?
Yes.
Can you use the audience?
Yes, I can. Just. Hello? Hello? Am I audible now?
Yes, Vardhaman.
Yes,
Carry on.
thank you, ma'am. Thank you. So first of all, I would like to thank Dr. Malik ma'am for being the strong support and a great guide for me in this tenure. And I'm going to start my secretary's report, which is working together for a brighter tomorrow of MOS. So friends, when I took charge in Nagpur, I already knew that it was a very big responsibility. I was filling the shoes of very illustrious yesteryear secretaries who had done tremendous work for our MOS to take the MOS to the current stature today. So continuing with MOS traditions, we decided to perform certain MOS traditions, and we also decided to have our own innovations. So continuing with MOS traditions, we had the first Diabetic Awareness Month, which was in collaboration with All India Ophthalmic Society. Maharashtra Ophthalmological Society, in fact, conducted maximum diabetic eye checkup camps all over India compared to any other state society, and for that we involved all district societies for the same. This was done with the help of radio talks, awareness articles in the newspapers. A lot of camps were conducted, and also there were awareness talks created for the general population. The Glaucoma Awareness Week was a huge success on the 14th of March. All over Maharashtra, in nook and corners of Maharashtra, each and every Maharashtra Ophthalmological Society's members screened glaucoma patient for that day, and we expect this numbers to cross more than 10,000 patients who have got benefited because of the same. The eye donation fortnight was hit because of COVID, as we know, but it was then we went virtually, and in collaboration with district societies, MOS conducted musical evenings, poster competitions, painting competitions, and webinars on eye donation for general public in collaboration with Rotary, with Lions Club, and more importantly, MOS practiced advocacy for helping our members to renew and extend corneal transplant center registration. There were public awareness TV shows which were continued like the last years, and we covered retina, glaucoma, ocular trauma, and refractive surgery also in the same. And like every year, we also had MOS Friendship Day to increase the bond of friendship between the MOS members and colleagues by a hurrah party at Saiban in Ahmednagar. But as ma'am said, actually this year was more about new beginnings, new ideas, and new ventures than only following the traditions. So first, MOS is proud to have now its own office, a physical office, which was inaugurated at the hands of our president in the premises of HP Desai Eye Hospital in Pune. MOS got accredited with the Maharashtra Medical Council with a gap of 4 years, and this now enables us to avail credit points for our members, and that's how the WorkOn has got 2 points this time. For the very first time in MOS, along with the TV shows, we also had radio interviews. So more than 40 such radio awareness talks were actually done all across Maharashtra, involving members all across Maharashtra. And this was the idea of our president, Dr. Malik Madam, so that we can reach out to the needy rural population, which has a great penetration by radio. We made many changes in the website itself, and more importantly, we added the former leaders to the website, right from Dr. YKC Pandit sir and Dr. Muljiani sir, who were the founders of MOS till this year. We have all former leaders on this website, and we also have a memorial page for our members to pay respect to them who have left us to the heavenly abode. Maharashtra Ophthalmological Society also for the very first time is on social media. MOS is on Facebook and on YouTube with a following in the tune of 1,300 to 1,500 members, and it is probably currently the largest followed social media state ophthalmic society of India. In the view of COVID, of course, we could not have physical conferences and physical CMEs, but again, that gave us new wings to the webinars. Of course, our webinars were well-paced every 15 days, and we tried to cover each and every specialty. And going beyond that, as Madam had just explained, we also had the MOSK Superstars and Super Singers competition, and we also had a mind, body, and soul to help our members in COVID times who were stressed. Then the COVID hit us. And when COVID hit us, MOS was actually the first state ophthalmic society in India to give alerts, advisory support to our members. And it was back in 1st of February 2020 that the first such awareness was created by MOS. And I believe that this was the first time in India. COVID not only gives, we did not only give support to the members, but we also created the webinars in Marathi local language. This was again for the very first time in India, and many other states have followed this suit and had the webinars in their own local languages all across India. So these webinars helped the staff in the OT and OPD in terms of COVID about the precautions to be taken and also about the patient care and their care of themselves. MOS goes green. Again, for the first time, we have a lot of stress into going green to reduce our carbon footprint and also to save a lot of money for Maharashtra Ophthalmological Society. So all communications such as Blink, which is a newsletter of MOS, now goes as e-Blink. I am very thankful to Dr. B. K. Naik sir, who has agreed to have JCOR, our prestigious journal, to go green. And from next issue, the JCOR is going to be sent to all the members by electronic formats and rather than having hard copies, unless, of course, you choose to do the something else. For the first time ever in the history of Maharashtra Ophthalmological Society, we have a huge membership updation drive. This drive went on for months. This was probably the most difficult task that we had to handle. And we are very happy that we could update more than 1,700 profiles accurately. And this work still continues. The module which was created for this was effortless. And I'm very happy to see that we have rectified more than 1,700 mobile numbers, emails, and addresses. We have rectified a lot of errors of the database, such as duplicate profiles of the members having more than one membership number, multiple members having the similar amount of similar membership number, and we also added 50 members whose name was missing from the database itself. When the database was completely taken care of, the next thing was that we saw the previous membership numbers, the patterns which were used and the formats which were used, they changed from year to year, and there was a lot of complexity in them. So we wanted to have a new, future-proof, simplified, uniform 5-digit membership system which should take care of this issues for the next at least 3 to 4 decades. So instead of having an alphanumeric number, we went for a 5-digit simple numeric number such as 00123. With all this information in place, now it was very due and the next natural step for us to give a new membership card with the QR code and the barcode to all our members. And we are very happy to actually make the first card for the founder of MOS, Dr. Rahim Muljiani sir, who was the founder, secretary of Maharashtra Ophthalmological Society. And as you can see, it is going to have a barcode and a QR code. This QR code is going to have all the necessary information about that person, including the membership number, the mobile number, email ID of the person, and this is going to replace your registration card in the conferences in future for MOS or MOSVIRCON. It was, I think, a dream which was seen for many years to have our own online election. And for the first time, again, we have the online elections which were conducted with our 4 excellent election commissioners, chaired by Dr. Quresh Maskadi sir. And I'm very happy to share that more than 1,200 votes were casted this year. our senior most members, who were all more than 90 years of age, actually voted for the first time after decades. This is a real representation of members of Maharashtra. This is the most democratic way of taking the society forward. And it was also done in the highest possible secure way by having 2 OTP systems. We also made sure that there were no associate members who could vote this time, which was the issue for many years in the past. For the very first time, Maharashtra Ophthalmological Society, as we know, the new members are our strength, and we have to go from strength to strength. So the yearly average for increase in membership for ratification has been in the tune of 100 to 120. So for the very first time, I think we have achieved a figure more than 2 times, and we have 257 members who will be joining Maharashtra Ophthalmological Society this year. Again, I think this is something which is completely a brainchild of our president, Dr. Malik ma'am, and this is going to be a huge thing for MOS members. This is the first ever Maharashtra Ophthalmological Society's group indemnity scheme. So at 1/4 of the premium of the individual policy, people are going to get benefits much more than what they could get, with the inclusion of criminal cases, inclusion of refractive surgeries, and also covering staff at minimal addition. And I would like to also thank Dr. A. Deshpande sir for the same, for executing this thing seamlessly, and Dr. Malik ma'am for her brilliant idea. Friends, we all know for any state society, the most important thing that we always look forward to having and hosting our coveted All India Ophthalmic Societies Conference. And for last more than 2 decades, for last 27 years, Maharashtra has been waiting for this opportunity. And we were very happy that All India Ophthalmic Society Committee, Dr. Mahipal sir is with us now, Dr. Namrata madam, they came all the way to Mumbai. They did a site inspection at the international level convention center that we have from Reliance. I would like to also thank Dr. Nayak sir and Dr. Natarajan sir for all the guidance and execution for the same thing. And after a long gap of 27 years, our dream has come true, and MOS has finally got the AIOC 2022. And this is a historic thing for MOS, and we are very, very happy. I think this is a huge achievement for our tenure. So, of course, at the end, I would like to say again, the first virtual conference of Maharashtra Ophthalmological Society, which was coordinated under guidance of Dr. Malik ma'am, Dr. Preetham, Dr. Videsar, and myself. First such state conference in India, more than 150 MOS speakers, more than 50 national speakers, 6 international speakers, including Professor Ioannis Palikaris, my mentor and father of plastic surgery. And you can see that the look and the feel of the meeting is like a live conference. We had more than 1,200 registered delegates, and it is expected that we will cross more than 8,000 to 10,000 delegates on YouTube in 2 days. So friends, I think after so many firsts, the first thing I would like to say is that I am so thankful for to Dr. Malik ma'am, my president. I think it was like a family, and she has guided me, supported me, encouraged me at every step. I'm so thankful to you, ma'am. Thank you very much. I'm so thankful to Dr. Preetham, our the scientific committee chairperson. He was like an elder brother to me and always supportive for the ideas. And Dr. Bide sir, who has been a great support, a great guide. And of course, we have, it is great to have a very, very meticulous treasurer with us. My gratitude to my family. I think I have given a lot of time to MOS in this year, and my family has been really, really understanding. So thank you so much, all of you. And to have in the finale, I'm very thankful to have my mentor, Professor Ioannis Palikaris, to be there for this WorkOn. So at the end, I would like to say that the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. Thank you very much, Aten. Thank you so much.
Wow, that was stupendous, Dr. Vardhaman. And you, led by Malik ma'am and Dr. Santosh and Dr. Preetham, have created such a high benchmark that I'm sure the forthcoming teams it will be really difficult to catch up with all those achievements in this year. With that, I thank you again. And now I invite the diligent and pleasing personality of Dr. Preetham to please come and share the award scientific committee, chairman scientific committee, to share the awards of academic year 19 and 20. Dr. Preetham.
Thank you. Thank you, Dr. Vaishali. Am I audible?
Yes.
Is my screen seen?
Yes, sir.
Yes. Yes.
So at the outset, my respects to the dignitaries, our guest of honor, Professor Palikaris, Professor Dr. Mahipal sir, Dr. Namrata Sharma madam, and to all the other dignitaries, senior colleagues, teachers who have gathered here. As a scientific chairman with a tenure of 2 years, a lot of my senior colleagues told me that, first year is tough, but then the second year is just a repetition of the first year. And that is exactly what did happen. The second year was nothing like the first year, and Corona made sure that there were new challenges to face, but we did it, I think, in the best way possible. So the second year was as new as the first year. Dr. Malik Madam and Dr. Vardhaman have already gone through all the various work that we've done from the scientific and academic side. And now I'm going to do the job of announcing the MOS awards as per the tradition of MOS. I'm going to announce the competitive award winners of the Nagpur MOSCON 2019. There were awards in 18 categories. In 13 categories, we gave competitive awards. And, it was surprising that in 8 categories, there were ties. That means there were same marks. When the conference got over and we were computing, I wished like IPL, there was a super over where I could decide, with whom to give. But unfortunately, there's no super over here. So we decided to give both the winners the awards. So let's start with the Best Free Paper Award in MOSCON 2019 goes to Dr. Jeevan Ladi for his work on smile refractive surgery. The runner-up for the Best Free Paper Awards for MOSCON 2019 jointly went to Dr. Zain Irfan Khatib for his work on intraocular lens calculation and Dr. Neeraj Asrani for his paper on perimetry. The YKC Pandit Award for Best Free Paper in MOSCON by an MOS member under the age of 40 were again both the runners-up, previous runners-up, both of them young surgeons, young ophthalmologists, Dr. Zain and Dr. Neeraj, for their work on IOL calculation and perimetry. The Suresh Limai Award, which goes for the best paper in retina, went to Dr. Sarvesh Tiwari from Mumbai for his work on subthreshold micropulse laser in central serous retinopathy. Congratulations, Dr. Sarvesh. In the category of the video presentations, the best video award went to Dr. Sarang Lambat for his video on surgery in vitreomacular traction. And the runner-up for the video awards again was a tie between Dr. Rahul Tiwari for his video on VR complications of cataract surgery and to Dr. Anand Pasari for his video on DSEC. The BG Kelkar Award, which is given to a postgraduate for work in community ophthalmology, again was shared between Dr. Swati Poptani and Dr. Ankita Rao, and a wonder of wonder, both their papers were on retinopathy of prematurity and both got equal marks. So congratulations to both of them. The best free paper by a postgraduate in MOSCON, the best free paper went to Dr. Vaidehi Bhatt from Mumbai for her paper on ultrabiomicroscopy in anterior segment ocular trauma. And the runner-up in this category again was shared by Dr. Prajakta for her work on presbyopia and Dr. Zelda Dadachanji for her work on keratoconus. Then again, the best free paper, this is the second award backed by Dr. Jeevan Ladi. So he is back 2 first awards. Congratulations to him, to Dr. Jeevan Ladi, sir. Again, the same paper, or his paper on lenticle extraction, backed the best paper by a private practitioner in MOSCON 2019. In the e-poster category, the best e-poster went to Dr. Nikhil Kumar Balkrishnan for his work on anterior lenticonus, and the runner-up again was shared between Dr. Swapnil Vidate for his work on macular hole and Dr. Ajit Joshi for his work on corneal perforation. The FDC award, which is given for best paper on ocular therapeutics, went to Dr. Archana Kota for her work on MMC, mitomycin C in trabeculectomy surgery. The Bell Pharma Award, which is given for best paper in surgical aspects other than cataract, again was shared between Dr. Madhavi Bijlani for her work on amniotic membrane versus MMC in TRAB, and jointly by Dr. Sonal Chaugule for her work on cyanoacrylate assisted excision of capillary hemangioma. The Best Innovation Award was awarded again jointly to Dr. Pranoti Nagvekar for her work on virtual reality in classification of glaucoma and Dr. Nupur Bhatt for her work on OCT in diagnosis of keratoconus. So these were, friends, the awards in 13 categories in Nagpur 2019. I congratulate all the award winners. And then we proceed to the nominated awards for this year, that is 2020. Now, every year we have nominated awards in 8 categories, and we receive a lot of applications. But because of Corona, we thought we will not receive applications. But mind you, MOS is not someone who will remain quiet. We had applications in 3 categories for the Dr. B.K. Chitnis Oration Award, the Dr. S.D. Athavale Award, and the Dr. Ishwar Chandra Award. And the winners are as follows. The Dr. V.K. Chitnis prestigious Oration Award goes to Dr. Prashant Bawankure from Nagpur. Congratulations to Dr. Bawankure. And I ask you all not to miss this oration, the V.K. Chitnis oration, which will be there tomorrow in Hall A in the session between 10 to 11:30. Please come there in huge numbers because this is a prestigious oration for our society. The S.D. Athavale Award for exemplary work in community ophthalmology goes to Dr. Swati Zawar. Congratulations, Dr. Zawar. And Dr. Ishwar Chandra Award, again a prestigious award, which goes to MOS member who has done exemplary work in ophthalmology and who's over 40 years of age, goes to none other than a past president, Dr. Gopal Arora sir. Congratulations, Dr. Arora sir. So with this, I end my announcement of the awards, and I would take my last few seconds to thank all those who've helped me throughout my tenure, my entire MOS scientific committee, my gratitude to my scientific advisor, Professor Dr. Ragini Parekh, my mentor, Dr. Professor T.P. Lahane, and my dear Dr. Rohit, who was a secretary for my scientific committee for 2 years and who's been running around doing a lot of legwork. I used to call him at odd hours, and the only thing he would say is, yes, sir, it will be done. Thank you, Rohit. My family for 2020, thank you so much. I cannot miss them out from here. Surena Malik, madam, I've written the names the way as to address them on phone. Dr. Santosh Bede, sir, and dear Vardhaman. Thank you so much. Last but not the least, my strength, my wife, Dr. Himalini. Now she has born with me. I promised her from tomorrow evening, this particular laptop is going to go in the cupboard for 7 days. Excuse me for that. My thanks to Mr. Sai and Numeritech for their IT support throughout the year, and to our event organizer, Mr. Bodhankar and team, for delivering a fantastic virtual conference, which is one of its kind. And the theme for this conference and the year was, where there is a will, there is a way. I think we've shown it enough. Thank you so much. And this is the selfie picture from the photo booth. I think you all must visit the photo booth and take this selfie, because this is something which you'll be telling your grandchildren many, many years from now. You will be able to show this. Thank you so much. Long live MOS.
Thank you, sir. Versatility. Versatility is like a white light. You only need prism to bring out the rainbow. Our next president is also versatile, like a rainbow. His different colors will be introduced to us by Dr. Anaga Hirur in a video. I request Mr. Bodhankar to play the video.
Check, check, check. Check.
Dr. Parikshit did his MBBS from BJ Medical College and MS from Government Medical College, Meerut, under Professor A.N. Kulkarni. He then completed his DNB and then FRCS from Edinburgh. He also has a Master's in Community Eye Health with distinction from the International Centre for Eye Health, London. Dr. Parikshit is a true all-rounder. He was the 55th All India ranker for the UPSC Civil Service exam. As an IPS officer trainee, he was a part of the 68th foundation course at Lal Bahadur Shastri National Academy of Administration at Mussoorie. A dedicated ophthalmologist, Dr. Parikshit has worked with an NGO hospital for 12 years and has been a visiting faculty at LV Prasad Eye Institute and the African Vision Research Institute at Durban. Apart from his own private practice, he is also a part of a group practice Atharva Netralaya and is an esteemed faculty at the D.Y. Patil Medical College, Pimpri and Queen's University, Belfast. Dr. Parikshit has been in various leadership roles in the past and has held various positions in the Maharashtra Ophthalmological Society as the Treasurer and the Chairman Scientific Committee. He has been the Secretary of the International Society of Geographic and Epidemiologic Ophthalmology and the Secretary of the International Society of Manual Small Incision Cataract Surgeons. He has also been the member of Academic and Research Committee and the Scientific Committee of the AIOS. With a keen interest in research, he has more than 90 publications in PubMed Index journals on cataract, pediatric ophthalmology, community ophthalmology, and residency training. An eloquent speaker, Dr. Parikshit has been invited to almost 30 countries to give lectures and to demonstrate live surgery in various conferences, including 7 instruction courses in the American Academy of Ophthalmology, and has done the country truly proud. A highly skillful surgeon, he has been a faculty aboard the Flying Eye Hospital of Orbis International since 2008 and has done numerous evaluations and audits of blindness control programs. Dr. Parikshit is a great orator and has 9 Best Paper Awards in the AIOS to his credit. He has also been the recipient of various awards like the Satyavati Madan Award, the Madhusudan Jamwar Award, the IGO Silver Awards multiple times, and numerous awards from the Maharashtra Ophthalmological Society. Dr. Parikshit is a prolific surgeon with a very vast experience of more than 65,000 surgeries from ICCE to femtolaser assisted cataract surgeries. He has performed nearly 2,000 pediatric surgeries and has had the unique experience of operating more than 100 surgeries in Baramati on 7 occasions, 3 of them with Professor Dr. Lahani Sir and Professor Dr. Ragini Parik Madam. His better half Bhageshri, herself equally brilliant and disciplined, is a professor of pathology and a good singer. They are blessed with 2 children. Siddharth is a distinction holder in MBBS from AFMC. Apart from being a committed and a dedicated professional, Dr. Parikshit tries to pursue his hobbies and has participated as an ace driver in the race across America, spanning 5,100 kilometers in 8 days. He is also a mountaineer and an adventure enthusiast. We wish you, Dr. Parikshit Gopte sir, great success in all your endeavors, and we are sure that under your able leadership, the Maharashtra Ophthalmological Society will truly reach greater heights.
Thank you and welcome, Dr. Parikshit.
So after introduction of our new incoming president, now I request Dr. Sunaina Malik ma'am, our outgoing president, to welcome incoming president, Dr. Parikshit Gopte. And I request our guest of honor, Professor Palikaris sir, and chief guest, Dr. Mahipal Sajdev and Dr. Namrata Sharma, to virtually install Dr. Parikshit Gopte as a new president.
First of all, let me remove this, which has graced my neck for the past 1 year, and hand it over to Parikshit virtually. He will actually be getting it shortly by courier. So sorry, Parikshit, that you couldn't wear it from today, but I welcome you and wish you all the best in your tenure. Thank you.
Thank you, ma'am. Now I request Dr. Vardhaman Kankriya to welcome incoming secretary, Dr. Shirish Thorat. And I request our chief guest and guest of honor to virtually install Dr. Shirish Thorat as new secretary.
Wow, what a proud and historic moment. I really consider myself blessed to be here in this one of its kind ceremony. I now take pleasure and I take pride in congratulating Dr. Parikshit Gopte, our new president of MOS, whose introduction video was just simply amazing. And yes, it takes great pride in welcoming you, sir. And I would like to say that I was searching the net. Your name suggests that it is a time-tested, tried, a great king. And I would surely say that civil services laws is definitely ophthalmologist's gain. Welcome, President. We are eager to hear you speak.
Thank you, ma'am. And thank you, dear friends. At the outset, I would like to thank all of you for having elected me as the president of our prestigious society. It's only thanks to your good wishes and the blessings of my gurus, my parents, and the support of my family that I am here. The huge mandate that you gave me in Aurangabad makes me anxious. Professor Sunaina and her team of Dr. Vardhaman, Dr. Santosh Bhide, and Dr. Preetam Samant have set a very high bar for us. Corona has been difficult times for all of us, personally and professionally. I hope I am not the first, but the last president of MOS who has to start his speech in a mask and has to do it virtually. I hope nobody has to do this later. COVID has affected not just ophthalmologists in private practice, but in government sector and NGO sector. It has affected even our retired ophthalmologists, our dear active elders who have now become something like placed under house arrest. Young residents do not have surgeries to perform as there are no camps or community work. Youngsters who have just started their practice just stare at empty waiting rooms because patients don't come in. And perhaps this may go on for many months to come. So it's a challenge that all of us have to face. In the MOS, I am lucky to have Professor Ragini Parikh as a chairperson of the scientific committee. She heads the ophthalmology department of one of the oldest medical colleges in the country, the Grant Medical College. And Dr. T.P. Lahane, it's going on or is it has stopped? And Dr. T.P. Lahane as the Director, Medical Education and Research. Well, we want to have their blessings to do something new this time. One is, we would like to have a cataract surgery training using a simulator for all the medical colleges in Maharashtra. Because there are so many youngsters who want to learn cataract surgery and there aren't that many opportunities for them. Second, when I learned my cataract surgery under Professor A.N. Kulkarni, like Shirish, he always asked us to just be careful about the cornea and the posterior capsule. But today's teachers face even more challenges because today patients are even more demanding, their expectations are higher. There is always a fear of having a litigation. So today's surgeons, the residents have lesser opportunities to learn. They don't learn enough of soft skills, which we know are today needed in medical practice. 2 years ago in 2019, in Dr. Gopal and Dr. Pangarkar sir's tenure, we had wanted to have a workshop with the Maharashtra University of Health Sciences so as to have good soft skills in the residency training, starting with ophthalmology as the first specialty. So I think we can do that now with Professor Lahane sir and Professor Ragini ma'am's help. We also want to reach out to all the district societies. 40 districts in Maharashtra, one of the largest societies that is there, like it was done in Dr. Jeevan Ladi's time. In fact, two of my predecessors, Dr. Marathe and Dr. Bawankure, practically visited every district in Maharashtra during their tenure. This may not be possible this time, but virtually we would like to reach out to even the smallest and the most remote district of Maharashtra, have a CME with them, with members or faculty from the MOS, from the local districts, and even from the AIOS, now that the AIOS leadership is sitting over here. Professor Malik and Dr. A. Deshpande and Vardhaman have started the indemnity insurance scheme, and I'm sure my team will wholeheartedly support it and take it further. The present MOS election has also shown that how much our members are still connected with the society. So we will continue this and hope to do it for all and more posts. Many of our members, especially youngsters, those who have started their practice or in small places, have problems with trade people or with equipment regarding AMCs, repairs, and contracts. So we plan to start a grievance cell, a grievance committee under the leadership of Dr. Milind Killedar, so that there is a common MOS platform for which they can all work. I would also want to thank Dr. B.K. Nayak for the wonderful work that he does for JCOR. And again, this year, we will be having another MOS member becoming the president of AIOS, and we look forward to that. And well, I cannot stop before I acknowledge a few people. Colonel Deshpande sir, under whose leadership I started my journey in MOS. Two of the presidents that I have worked with very closely, Dr. Jayant Laurkar and Dr. Salil Gadkari, who are no more with us. And I know my journey is going to become very easy because I have two very good friends, Dr. Shirish, who has been my senior and mentor since residency days, and Dr. Pankaj as my two colleagues in this. And also my parent body, the Pune Ophthalmology Society, with Dr. Shrikant Kelkar, Dr. Zabar, Dr. Udayan Dikshit, and all the rest. Finally, MOS is for its members. And we know what the members are. All our members are, many of them are comprehensive ophthalmologists. They are in some ways jack of all trades, working in the districts, working in the talukas. The MOS will firmly stand behind all its members. That's a promise that I make. And of course, I would also like to acknowledge my friend, Dr. Nitin Upadhyay, who as the president of Vidarbha Ophthalmology Society has traveled all the way over here. And of course, before I stop, this is a virtual conference. There is no banquet after this, so I have to go home. So I have to thank my wife, a very intelligent woman. I think the only thing she didn't do very intelligently was marry me. So my wife and my kids, because all the travel that I do, all the work, the extra work that I do is possible because of their support. And once more, thanks to all of you members. It's because of you that I am here. And I promise to work hard the entire next year for you. Thank you.
Thank you so much, Dr. Parikshit. And on behalf of all the district societies, I look forward to having a great year ahead and working with you and your superb team. I now invite the Prince Charming of MOS, Dr. Vardhaman Kankriya, to give an introduction to his mentor, the illustrious Illinois Palikaris sir. Vardhaman, over to you.
Thank you so much. Thank you so much, ma'am. And just a second, can I just share my screen? So I think it is a, yes, thank you. It is immense pride, gratitude with which we actually welcome my mentor and the chief guest of today's function, Professor Ioannis Palikaris. We call him the engine of innovation with the human face. So basically, Professor Palikaris is a life spent on innovation and on transmission of knowledge for generation of ophthalmologists around the world. He's a historic figure in the world of in ophthalmology itself, and he's considered as the father of modern refractive surgery, thanks to his enormous and pioneering contribution to technological advancements, especially in the development of LASIK, epi-LASIK, and race tracing technology. Many wouldn't know that Professor Palikaris was actually trained first as a vitreoretina surgeon and then found his love into refractive surgery later on. Professor Palikaris' research interest expands in all fields of ophthalmology, including refractive surgery, visual optics, medical lasers, biopolymers, retinal surgery, and image analysis. But most importantly, in design and development of microsurgical instruments and surgeries. His most significant impact in refractive surgery and the most famous contribution in ophthalmology is in the form of LASIK. He performed and studied LASIK for the first time in 1989, and following year, he performed the first LASIK on a patient in University of Crete. Since then, he had a great impact in the field of ophthalmology, while he is considered as the father of LASIK, the most worldwide acknowledged and used surgical technique in correcting refractive errors at present. For patients, LASIK became synonymous with refractive surgery, similar to Xerox is to photocopy. Another significant invention of Professor Palikaris is ray tracing technology. And of course, we all know that Professor Palikaris has developed a lot of other tools, including rotating brush for PRK procedures and the innovation of AP LASIK itself for thin corneas. Professor Palikaris also has a lot of contribution outside of optics and refractive surgery in study of ocular rigidity, hydrodynamics, and its association with diseases such as glaucoma. He has published more than 200 articles in international journals, but most importantly, most of these articles are having very, very high impact in changing the way we practice ophthalmology today. He holds more than 20 patents related to optics and ophthalmology. Professor Palikaris has been awarded more than 15 very, very prestigious international awards for his groundbreaking contribution to refractive surgery, most notably the Barraquer Award from American Academy of Ophthalmology, the Charles Kellman Innovators Award from the American Society of Cataract and Refractive Surgery, the Bincroft Medal, which is the highest medal from the European Society of Cataract and Refractive Surgery, and he has been also the president of the prestigious ECRS in the past. Along with his amazing innovations, he also is humanitarian. Professor Palikaris and his team has served in the isolated areas. He has served in the isolated areas. One second. He has served in the isolated areas, which is called as a University of Mountains, with his wonderful wife, Mrs. Varvara Terzaki Palikaris, and founded University of Mountains, a not-for-profit organization to provide eye care to the people of villages and mountains who do not have access to the healthcare. He is a global mentor. Professor Palikaris has been strongly supported and provided mentorship for fellows around the world. Many of Professor's fellows have contributed significantly to the scientific community at a global stage. Professor Palikaris has been a mentor and a father figure for me personally. He has guided, supported, and mentored me in my professional and personal life since 2011. When I joined Professor as a fellow, this was in 2011, he actually treated me like his family. He introduced me to to the Greek culture. He invited me to stay with him and his family for a week's time to celebrate the Greek Easter in a small, beautiful village of Iomanas. That Easter is a lifetime memory for me, and he has a memory for me. He has deep love for India and Indian culture, especially as Greece and India share the common thread of ancient cultures. So Professor Palikaris has gone out of his ways to support his fellows. And one such instance has been that last time when he actually came to India to inaugurate our eye hospital, and we also named our refractive surgery center and department after him as a respect, he actually made a lot of arrangements to change his schedules and actually came for the same. He personifies a mentor who is a friend, a guide, a guru, a father, and a best critic. Professor says to all of us fellows, I don't want to create fellows. I want to create future mentors for the future fellows and innovators for the future patients. Thank you very much. Here to Professor Palikaris. Thank you.
Just a minute, Vardhaman. Before we invite Professor Palikaris for his wonderful talk, which you're all looking forward to, I would like to invite Dr. Mahipal Sachdev, the President of All India Ophthalmological Society, which is our parent body, to give us a few words of advice. Mahipal, if you would.
Yeah. Thank you very much. Good evening, everybody. Dr. Professor Sunaina Malik, Vardhaman, Preetham, Santosh, incoming President, Dr. Parikshit, Shishir, Pankaj, Ragini. It's always a pleasure being part of the Maharashtra Ophthalmic Society meeting, which I think I haven't missed for several years. I think over the years, what I've seen is that Maharashtra has really taken the lead in ophthalmic training, education, as also showing great commentary and doing a lot of community work as also eye banking work. I think it's a very, very vibrant society. And as all of us heard from these speeches that were given by the incoming president, as also by the outgoing president, the secretary, Preetham, they have really done human service. I think the number of cataract surgeries that are being done in Maharashtra with great, excellent results is anybody's pride. And we have accomplished surgeons, accomplished teachers, and accomplished educators and skill transfer people who are there in Maharashtra Ophthalmic Society. If you look at any presentations or any conferences, I think Maharashtra Ophthalmic Society is leading. The journal has been with the people from Maharashtra. The presidentship, Dr. Nayak, is going to be taking over after my tenure. I think there are lots and lots of contribution, great people like Dr. Muscati, Dr. Muljani, senior people who have Dr. Keki Mehta. I think your society is really doing a great work. Again, what I would wish to point out is that from a medical legal aspect, again, Maharashtra Ophthalmic Society and its members are there to help and guide the entire ophthalmic community. Another thing is that when we made the consent forms, I think Maharashtra Ophthalmic Society members were the first to bring out the translation in Marathi, which has been circulated. So the kind of passion and the great determination and the strength that is shown by the Maharashtra Ophthalmic Society is really very, very, I would say it is one of the best in the country. And I would say that I have a special love for Maharashtra. My first live surgery demonstration that I did was in Bombay on, I think in Sion Medical College way back in 92, 93. And every time I come to Maharashtra, whether it be Maharashtra Ophthalmic Society, Vidarbha Ophthalmic Society, whether it be Pune, whether it be Bombay, I think the love and affection that I get from all of you is really great. Parikshat, I think, is a great guy. And the zeal with which he does SICS work, I would say the zeal with which he does contact lens, community ophthalmology, everything, Orbis, I think that's going to be phenomenal for you people to have him as a president. Yes, I have participated in a few of your Maharashtra Ophthalmic Society webinars, which have been very vibrant. I think the society has taken the lead in uniting everybody in this difficult time of COVID, and the webinars have been really par excellence. I am wanting to give all my best wishes and support as and when required by Maharashtra Ophthalmic Society as President AIOS and as an individual to see that the members of Maharashtra Ophthalmic Society benefit and they keep on going up the ladder of academic excellence and skills. So with these words, I'll wish you all the very best to the team that has done excellent work and the incoming team for taking the members of Maharashtra Ophthalmic Society along with them and to keep them motivated, inspired, and give you all the very best. Thank you very much.
I'm sorry to interrupt. We have missed out on introduction of the team because leader is basically works for his team. So now Dr. Parikshit Gopte will introduce his team.
I'm sorry about this, Vardhaman, but we'll keep this really very short because I think we are going behind time. Yes, this is the Honorary Secretary, Dr. Shirish Thorat from Akola. Dr. Shirish was 1 year my senior and has taught me cataract surgery practically. So he's been like an elder brother, but now, well, I have, let's see who does more work between us. So thank you, Dr. Shirish. And Shirish, of course, has a huge, humongous practice in Akola. Everything in ophthalmology. Yeah. Dr. Ragini Parikh ma'am needs no introduction ever in the Indian ophthalmology circles. We are really lucky to have her as the chairman scientific committee for next 2 years. Thank you. Welcome, ma'am. And Dr. Jignesh Daswala, Jignesh bhai sitting over here, forever young and forever enthusiastic. And in fact, he always overshadows and overshines everybody who is around him. So I will have to be more careful. Otherwise, people think Jignesh bhai only is the president. So next, please. Yeah, and Dr. Pankaj Shaha. Dr. Pankaj has been my junior in BJ Medical, very academic person from Jalgaon. And I think the most dynamic fellow amongst all three of us, pushing us to do newer and newer things. Thank you, Dr. Pankaj. Well, again, Nayak sir needs no introduction. He's been the editor of JCOR since its inception, and sir will be the president of AIOS this year. Our advisory board is, of course, Padma Shri Dr. T.P. Lahane sir, my PG teacher and mentor, Dr. A.N. Kulkarni sir, and Dr. Quresh Maskati sir. None of them needs any introduction. Ex officio, we have Dr. Sunana Malik, Dr. Vardhaman, and Dr. Preetham to help us. Zonal members, Dr. Anagha Herur, who made that wonderful video, and Dr. Harshavardhan Ghorpade. From Marathwada, Dr. Swati Shinde, and Dr. Vivek Motevar from Nanded. Zonal members, Dr. Darshana Shah from Jalgaon, and Dr. Abhijit Vaidya from Akola, and Dr. Manoj Oberoi from Nagpur. Dr. Nana Sahib Khare, who will be the organizing secretary for the next MOSVIRCON in Nasik. Again, a friend and junior from BJ Medical Days. Legal advisor, again, Dr. A. Deshpande sir, as Mahipal sir said, he's there as advising all of us. Well, for the grievance cell, which we are setting up for the first time, Dr. Milan Killedar, sir, who's taught me Squint, and my senior in Pune, Dr. Jeevan Ladi. For academic advisors to work with the MUHS, Professor Vilas Wangikar, sir, from Aurangabad, and Professor Shriram Karandikar, sir, from Nagpur. And of course, this got butt in, and well, there are still the second vice president, the joint secretary, and the joint treasurer. So we are all waiting with bated breaths for those 1,300 votes to be counted, and we'll get to know that in a few minutes or an hour's time. Thank you.
Thank you, Gokte sir. Now I invite Professor Palikaris for his inaugural address. His topic is the journey of innovation in ophthalmology.
Good morning or good afternoon. Probably we have some different on the time here. Do you hear me, first of all?
Yes, yes, Professor.
Yes, yes, we can hear you.
Dear President of All India Society, dear President of Maharashtra Society, dear colleagues, friends, it is a big pleasure for me to join you. And of course, it's a big honor also to be among you. Because what Vardhaman said before was not absolute right. That's been that when Vardhaman came here in Crete, in our university, I believe that he was much more influential to our life than what we have done to his profession. And today, India, for me and for my family and many from my doctors here, is like the second country. And you have to be very proud about Vardhaman, because after he came back in India, many Greek doctors, they came to his hospital to be trained. So I believe this is really very important what Vardhaman succeeded. And of course, he makes also me to feel very proud about him and about my, let's say, target to help some new doctors to become mentors later on. So now I will try to share my screen in order to present from here my presentation. Do you see my screen?
Yes, Professor. Yes, Professor.
All right. Besides the fact that Vardhaman has already explained everything from my screen, let me go here. You see this is a full screen or also part of my screen?
Right now it is a part of your screen, Professor. You have to go to the, yeah. You may have to just click on the.
All right, now this is a full screen and I can.
Slideshow, yes.
Here. All right.
Perfect, thank you.
I have a full screen. So regarding my journey of innovation of ophthalmology, I think Vardhaman said already everything that's happened in my life during my profession. But I would like to tell you that I don't want to be a doctor. my choice was to be an architect. So that's by default, I came in the medical school. So when I was starting my career in ophthalmology as a resident, it was in Zurich, 1977. And as you can see here in this sketch, which has been done from one from my colleagues at that period in Zurich, my first investment was to make a windsurfing for surfing in Zurich Sea, of course. And in this drawing, you see by side also a few, let's say, instruments I was designed in that period when I was resident in Zurich. So you recognize here probably a plastido disc and trephination here as some other small instruments. So for that period, I wanted really to do some research, let's say, and do some innovative things. When I went to refractive surgery timeline, you see here many people on the screen. Somewhere you see myself also around 1990 was a period I developed LASIK. But for me, the most important persons in these slides are, of course, Baraker and Fyodorov. I think those people, they have the major, let's say, merit in modern refractive surgery. The before LASIK period, I was working with some new ideas also. And this is my thesis when I was in Zurich. And this is the publication of that period on the preoperative placido photography in keratoconus and its meanings in conjunction with postoperative astigmatism. I published in Graphics Archive here. What I have done actually, I took placido photographies that period, and I was using a very primitive computer to measure, let's say, the dimensions of the several axes in topography in order to find a way to identify, let's say, the structure of the cornea. It was, let's say, the very first kind of topography, let's say, that period. What I could make it in this study, I could predict the shape of the opening of the cornea, of the recipient cornea, when we have done, of course, a round trephination because of the strength of the cornea and based on the placido here photographies, I could identify sorry, come back here. Let's say the shape of the opening and of course then the strength of the transplant in the opening. At the same time, I was designing a trephine which is very similar to the Baron trephine. You see here on the top left, it was a 3-edged trephine with a section, was actually the same concept like the Baron trephine. After that, it was the period of the arcade, which became very popular, and I wanted to make a diamond knife which can make more precise and more safe, let's say, cuts, and also to deepen the cut from the center to the periphery, because we knew that when you go 90% of the thickness of the cornea, you generate the highest effect on the cornea. So this is my pivot knife. Which was the knife which was really very impressive how easy and how safe you can do a very precise, let's say, incision in the cornea at that period. Also, the relaxing incision, for the arc relaxing incision was also very popular at that period, of course, doing with a diamond knife before the laser era. And I designed this architome from downward at Kent. So I could use this architome to make very precise incision in the length, in the arc, and in the depth. So I could customize, let's say, any incision using this precision instrument. And on the left, you see from our publication that we had developed a kind of nomogram, and we could identify how many cuts, how long, and how big and how deep has to be done in order to have the best outcomes. PRK started at that period, and of course, last area we have already some first experiments with X-ray laser for 1960s already. Torquel has done the first corneal excision, and L'Esperance and McDonald the first PRK. The FDA came much later. At that period, but the first problem was how we remove the epithelium. So I designed this brush which is, I was using actually a scrub from our hands in the surgery, and then I cut it around it from this scrub, you see that, apart, and then I rotate it, and then I could make several brushes that you can see here to remove the epithelium. I get also a patent for the United States. It was much before the Amoy's brush comes in the market. PRK becomes not very popular, of course, because of pain management, slow visual recovery, and corneal haste and regression. So then we have to overcome this problem. So I came to the idea to ablate not on the surface, but deep in the stroma. So I have designed my first microkeratome you see on the top left here, with a very primitive keratome just for the rabbit experiments and the healing studies. And then I have my very first keratome for the human, which is down below, which is an oval opening, and the publication on the period. This is a video of the very first cornea cut in the human eye with a microkeratome in order to make a flap. This keratome has been manufactured from Polytech. I have designed the ring. You can see here, I have some holes on the side and a small plaque also. So the plaque is used to identify how far the oscillation head of the keratome has to go farther. So somehow this was a way, they say, to predict the size of the flap. The first flap, of course, was not as thin as today. You realize that the very first flap was very thick and very rigid. This first flap was, I think, about 300 microns. So you see that the flaps come immediately back. And of course, the hinge is very wide, and the size of the flap also is quite small. But it was just enough to make the laser ablation, as you will see on the next slide with the very first excimer here. You see the border of the ablation in the flap. Now, LASIK in the beginning has no limits. We started to make high corrections with small optical zones. We don't have any idea what's happening in the future with several optical phenomena and also with the biodynamics of the cornea. So the first we faced was the halos in very small ablation zones, but quite stable results. You see here 11 years after LASIK, very steady outcome. But at the same time, we start to rethink about the quality of the cuts and what was the effect of the flap on the biomechanics of the cornea. So we discovered, of course, with new technologies, the high order and the low order aberration, and we could have a much more precise, let's say, view on the optics on these corneas. And of course, ectasia was started also at that period, and then we have a better understanding about the biodynamics and how important it is to make a very thin flap and preserve a certain thickness of the cornea. So that's why when you see this timeline here, we start from PRK. Because of the PRK problem, we come to LASIK. And then because of the LASIK problem was the risk of cornea ectasia and the apodial flap induced aberration, we started again to think about the advanced surface ablation, to go to the surface. So at that period, I also developed epi-LASIK in order to have a certain indication, like thin corneas, flap-related complications, flap-induced aberrations, preoperative dry eye, which was a major problem later on, and some dystrophies. So the epi-LASIK has an idea, instead to cut the cornea to separate the epithelium from the surface of the cornea. So we could make it separate the epithelium very safely under the basic membrane, if you can see here. So we don't destroy any epithelial cell with this separator. And of course, this became very popular. You see here all the companies, they've done, let's say, microkeratomes redesigned somehow for the use for epi-LASIK. The problem was that the first day, the result was amazing, very clear like LASIK. But the third to fourth day, the cells, they start to die. So I mean, the flap cells and new cells, they start to generate from the cornea. So this 3-4 days period, we have a loss of line of vision. Of course, has been recovered, but the results was not the optimal one. And 94, 95, we start to think also about the quality of the vision and how evaluate, let's say, the total optical system. So I have a friend in Kiev, Vasil Molebny. So I asked him to make for me a tracing system to trace, let's say, line by line, all the refraction in the eye. So we developed the ray tracing technology. Today is very popular, and in India there are many units I know, and you can make many things with this machine. It's amazing. I mean, you can predict toric rotations. We can, let's say, re-estimate the rotation or the false rotation of the toric lens, and he guide you how you should re-rotate or reposition the lens in order to have the best results. And lately, we have developed this lens dysfunctional index, which actually, in this case, this is a 475 here. That means we have a total refraction here on the right. We have a blur image, as you can see, so we can find out what part of this blurring effect is come from the cornea and what come from inside of the eye. So the cornea here, topography show us a very clear image projection. So everything comes from inside because of the lens, of course, and you have here some distortion of the quality of the lens. So this is a pre-cataract, let's say, stage where we can understand better the patient concerns, because many patients, they come, they have a kind of difficulties to read. They are not very happy with the lighting. They still have 20/20, but the cataract has started. So this tool can give us more information on that. In our days, of course, we came after the LASIK period with the use of the femtosecond in our life. And you see that after 2006, femtosecond came in our life, and SMILE today is very, very popular. All these here platforms you can see here, they can be used in several ways to optimize any kind of refractive correction. I don't like to stay longer here, but I would say that any platform has some certain, let's say, super achievement. Some platforms that don't do it very well. I don't go deeper on that, but the ones that experience, they understand what I mean. Now, of course, the next ultimate goal is to have a cornea surface which is absolute, let's say, corrected with any irregularity. We know that the best way to correct any cornea irregularity is the use of the hard contact lenses. So if we put a contact lens on the eye, we achieve the best corrected vision I could. This is a perfect optical system because the contact lens, the hard contact lens, has an absolute spheric surface. I came to this idea, by the way, much earlier, in around 1990 to 2000, and I developed this palm technique. The idea is to reproduce, let's say, on the cornea surface, the same quality of the optics from the contact lens. So I use a contact lens, I put under the contact lens a thermo-reversible material, and I molded a new surface on the cornea. So I removed the contact lens then, and then I was ablating with a PTK. Here you see on the right side how nicely I could correct all this irregularity on the left. So it was a very impressive, let's say, technique, and we started to use to make training around the world. But we failed because actually during the ablation rate, we have some, let's say, side biomechanical effect, and was not very precise the result. Now, if we're going to SMILE today, I can raise the same question. Is any intracorneal lentil which can correct 100% the surface irregularity? Theoretically, yes, by customized ablation and strong profiles. But you know very well that practically it's almost impossible because of the technology limitations. Even topo-guided X-ray laser today, they cannot do it. Now, it's a way to reproduce the same surface irregularity in an intrastromal cut and generate a custom lentil which include all these irregularities in one surface, and on the other, the total spherical refractive error. This is, let's say, the ultimate wish and goal, of course. I developed a new technology which can fulfill these needs today. So the idea behind this, again, I use a gel, but this gel, of course, is a different one than the previous with the palm, because this gel has not to be ablated. It has to be used just to fill the irregularities of the cornea. That means it has the same optical parameters with the cornea. So you see the concept here with the gel. I put a cone on the top of the cornea, and then I will use UV light, and the gel solidified. That means I have a new, actually, super cornea surface. Then I make my first cut with this complex. So the first intrastromal cut is parallel to the new cornea surface, actually, with the gel. But intrastromally, this is mimics the irregularity of the top of the cornea. Then I remove the gel and I put again a second cone without gel. And this time I do a parallel cut from the surface of the real cornea. So what I have done, I generate an intrastromal lentil, which includes all the surface irregularities. When I remove it, I have a super regular surface. Now, what I like to show you here is a very impressive video. You will see how this gel solidified and how it works. This is the head of a normal femto laser machine, by the way. This is, I think, from Alcon or Wavelight. If you are a user for that, you recognize this, the cone. I just change the shape on the top of this cone, and this became curved. It's not flat. Now I put the gel. It's a very simple process. Then you can put on the top this cone or any other cone, by the way, that can be used by any machine. You irradiate by 1 minute. It's a very fast process, of course, that the gel become hard. Then you see the gel is quite sticky. That means the eye somehow is fixed, all right? It's not moving. Now, just to demonstrate to you, I try to flip up the cone very carefully. So the cone is very clear, you know, the surface is very clear here. And here, just I have a new cornea, let's say, absolute spherical surface. Now, just I try to remove this material just to see how nice looks this, let's say, interface. The new cornea interface is like a custom contact lens, by the way. So I think you understand the concept here. And what I have done also, I was trying to prove that the cut through the material is the same quality. And you see, this is the cut intrastromal without the gel, with the femto laser. On the right is with the gel. And you see the right cut is even better than the left one. So this is the concept of this procedure. The next toy, what I'm currently working on also, is how we can bypass the problem with the PCO formation, the misalignment of the lenses. And you know, all of you, that the premium lenses today, they are needed a very precise, let's say, positioning in the eye. The effective lens position is very important in this type of lenses, of course. And of course, PCO is no doubt that could be also a problem, and also tilts. And in particular, if we like to exchange for some reason the lens, we need to have a safe, let's say, capsule environment to do that. And in pediatric ophthalmology, this is very important because we know that we have to change the lens at least 2 times, let's say, and we have much higher fibrosis. I developed this ring which somehow expands the peripheral part of the capsule. What I do, I will reconstruct, let's say, the shape of the capsule. I don't leave the capsule to collapse. Okay, this is not a new idea, but this particular ring we have designed have several, let's say, features that are unique, because this is one size fits all, can fit to any capsule size. This has a certain tricks how you stabilize the optic of the IOL in the center of the ring. There are some specific clips to do that, for example, and spacing also is very important, and material is very important. So here you see an eye immediately after the surgery, where you see the very clear, of course, optic of the lens, very nice center, and on the side you can see here the 2 special clips that are used to clip the optic inside. So you ensure, let's say, the lens position, the effective lens position, which is very important for the calculation of the IOL, and also you don't have any PCO. And this is a case after long period. You see the upper picture is for one eye, and the other is the other eye for the same patient. The first one is with the ring, and the other without the ring. So the second eye start already to have PCO by 8 months. The same is here, which is 6 months after the surgery. The same patient left with the ring, right without the ring, you see on the right already PCO started. And here is the most important thing, slides, because here I demonstrate to you how nicely the optic of the IOL is placed just in the center of the anatomy of the previous, let's say, normal human lens. You see the anterior capsule, the capsulotomy is upward from the optic here, and you see also a great distance between the optic of the IOL and the posterior capsule, which is, as I said, is absolutely clear in this case. Okay, come back to Zurich, and I'm finished. I like to say that in Zurich, beside the first sketch, I have another sketch, this one, because I break my hand by skiing, and then I was using the gips, and I went to the clinic to serve the patient. So the guy who made this sketch said that Palikaris can use the break hand to measure the intraocular pressure, or probably the rigidity of the eye. Of course, at that period, 50 years back, I never thought about my rigidity project. But the beginning of 20s, 2090 to, let's say, no, 2000, close to 2000, the beginning of the century, I started to think about how important is the dynamics of the eye, and particularly the hydrodynamics. So I introduced hydrodynamics as a concept because all of you understand that when the blood flows inside the eye, in the choroid, take a space inside the eye. So this space, let's say, has to expand the eye somewhere. So one place which is expanded is the cornea, and we see it when we do, of course, the IOP measurement with the Goldman tonometer. Also, what's happening at the same time, the flow here is much faster, so from the aqueous of the arterial chamber. If the eye is myopic and is, the sclera is thin, we can see also that the whole globe will be expanded. But I think the most important place is here in the optic head, because here, because of the anomaly cribosa, you know that when the internal pressure is increasing, the blood flow is blocked somewhere here. And it's very important really to understand all these dynamics. I developed this complex system, as looks like. This is a micro pump, but it's very simple to use, because what I do actually, I use a very small needle and I put this inside the eye before any cataract surgery. And the system just pressurizes very small micro amount of water in the eye, and then follow up the internal change of the pressure and everything related to the blood flow. And of course, we have done this to be non-invasive. And in this instrument, I have much more information because I compare the same, right, at the same time, the heart rate, as you see, the intraocular pressure, and the blood flow, and the rigidity. And there are a lot of information that can lead us, let's say, to a better understanding of this hydrodynamics. This comes all this in this book, which, by the way, comes next month out and published. So I would like to thank you for your time and your patience. And I hope that I don't take so much time. And I hope I will be soon in India to see my friends. Thank you.
Mute. Vardhaman, Dr. Vardhaman, you're on mute.
Hello. Yeah,
Yes.
thank you so much, Professor. I think this was once in a lifetime opportunity for many ophthalmologists here in India. And we are so thankful for all your innovations, which have changed the lives of millions of patients around the world. And of course, all the ophthalmologists. Thank you very much for your time that you have spent with us and all your generosity. Thank you for Maharashtra Ophthalmological Society.
Thank you very much. Have a good day.
Thank you, sir. Gratitude is the most exquisite form of courtesy. Now I invite Dr. Shirish Thorat, sir, our new secretary, to give vote of thanks. And before that, from our MOC side, that means me, Dr. Neha Deshpande, and Dr. Vaishali Une, madam, we are signing off from this wonderful virtual inauguration of the conference. Thank you.
Good evening, all. On behalf of organizing committee of MOS, I really thank Father of Modern Refractive Surgery, Professor Palikaris, sir, for sparing his valuable time for this function and delivering wonderful lecture. It is our great honor to have you as a guest of honor, sir. My special thanks to Dr. Mahipal Sachdev, President AIOS, who accepted our invitations. Thank to Dr. Namrata Sharma Madam, Secretary AIOS, for sparing her valuable time. Our ongoing president, a very enthusiastic and innovative lady, Dr. Sunana Malik Madam, and her team MOS 1920, Secretary Dr. Vardhaman Sir, Treasurer Dr. Bhide Sir, Chairman Scientific Committee Dr. Pritam Sir, who have taken MOS to new heights by their work. Thank you everyone for their tremendous work toward the MOS. Thanks to Mr. Bodhankar and all staff of Pancharatna Hotel for providing technical support. My special thanks to Mr. Prabodh of Yash Audiovisual and all sponsors for making this program successful. Thanks to Dr. Prakash Kankriya sir, Dr. Jignesh Taswala sir, Dr. Nipin Upadhyay, President VOS, and Dr. Piyush Bansal for attending this function physically. Special thanks to MOC, Dr. Vaishali Une Madam and Dr. Neha Deshpande. Thank you. Now I request you to stand for national anthem.
सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाए तब जय गाथा जन गण मन नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की
जय जय Thank you.
Thank you all. We will assemble in a little while, in 5 minutes for the GBM. Please don't delay.
Yes.
Thank you all.
Thank you. Thank you, everybody. Thank you, Professor. Thank you, Dr. Mahipal, sir. Dr. Namrata, ma'am. Thank you, everybody.
Thank you.
Thank you. Thank you so much.
Thank you to Dr. Vaishali Une for conducting this. Dr. Neha, fantastic. Very well done.
Very well done, honestly.
Thank you,
Wonderful.
ma'am.
And I personally would like to thank Professor Palikaris and Dr. Mahipal and Dr. Namrata for joining us. And congratulations to Parikshit and his new team. Thank you so much. Thank you to Bodhankar Events for the marvelous